Meeting can be called to order. I believe we have quorum, so we will call the meeting to order. Honourable members, at the committee of January 18th, 2022, the committee agreed that at the beginning of each meeting we would observe a moment of silence to commemorate the lives lost in Alberta due to drug poisoning, overdoses, and illness of addiction. So this time we're going to take that moment. Thank you. Welcome members and staff in attendance to this meeting and of this select special committee to examine safe supply. My name is Jeremy Nixon and I am the MLA for Calgary Klein and the chair of this committee. I'd now like to ask members and those joining us, the committee at the table, to introduce themselves for the record. Starting to my right.
Good morning everyone. Nicholas Milliken, MLA Calgary Curry.
Miranda Rosen, MLA for Banff Kananaskis.
Danny Al, Fort McMurray Wood Buffalo.
Good morning, Mickey Amory, Calgary Cross.
Good morning, Nancy Robert, Clerk of Journals and Committees.
Good morning, Aaron Roth, Committee Clerk.
All right, now I'd like to welcome those joining us remotely, starting with Michaela Fry, to introduce themselves for the record.
Good morning, Michaela Fry, MLA for Matt.
And MLA Stefan. Oh, Mr. Stefan, you are muted.
Let's try that again. MLA Jason Stefan, read yourself.
Excellent. Thank you, Mr. Stefan. I would like to note for the record that the following substitution, Mr. Williams, who... Oh, there we go. We do have Mr. Williams online now. Mr. Williams, can you introduce yourself for the record?
Yeah, MLA Williams, MLA for Peace River, and substituting in for the Deputy Chair, Tracy Allard from Grand Prairie.
Perfect. I'd like to note for the record the following substitutions. Mr. Williams for Deputy Chair, Mrs. Allard. Thank you for that. A few housekeeping items before we get started. I would note for members that masks should be worn in the committee room except when you are speaking, and members are also encouraged to leave an appropriate amount of physical distancing around the table. Please note that microphones are operated by Hansard. Committee proceedings are live streamed on the internet and broadcast on Alberta Assembly TV. The audio and video stream and transcripts of the meeting can be accessed via the Legislative Assembly website. Those participating by video conference are encouraged to please turn on your camera while you are speaking and mute your microphone when you are not. Members participating virtually who wish to be placed on the speakers list are asked to email or send a message in the group chat to the committee clerk, and members in the room are asked to please signal the chair. Please set your cell phones and other devices to silent for the duration of the meeting. Then we will go to item number 2, approval of the agenda. Can I get a motion of the floor that the agenda for February 15th, 2022 meeting of the Select Special Committee to examine safe supply be adopted as distributed? Motion from Ms. Rosen. Is there discussion at that point? Yeah. Any discussion about the agenda? Hearing none. All in favor, please say aye. Aye. Everybody online in favor, please say aye.
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 Perfect. Going forward, I'm just going to ask that as a collective answer. So if you're online, feel free to say aye or no when appropriate. Going on to number 3, approval of the... Oh, sorry, that motion is carried. Going on to item number 3, approval of minutes. Up next is the approval of minutes from the previous meeting. Are there any errors or omissions to note at this time? Seeing none, would a member move the approval of the minutes? That the minutes for February 3rd, 2022 meeting of the Select Special Committee to examine safe supply be adopted as distributed. MLA Milliken. Any further discussion? Hearing none, all in favor, please say aye. Excellent, that is carried. All right, that brings us to the main event, presentations. Honorable members, as its February 3rd, 2022 meeting, or at its February 3rd, 2022 meeting, the committee invited Dr. Julian Summers from the Center for Applied Research in Mental Health and Addiction at Simon Fraser University, who is preparing an evidence review for the Ministry of Health, to make a presentation to the committee in relation to that review. I would now like to call upon Dr. Summers to make his presentation. Dr. Summers, welcome, and we look forward to hearing from you. You have 30 minutes.
Thank you, Mr. Chair and honorable members. It's an honor for our team to be invited to collaborate with public servants in the Ministry of Health on the providing support to the committee. And it's a personal honor to be here today representing that work with you. My understanding, housekeeping-wise, is that slides will be presented, and I'll signal when I'm moving forward, so I'm still on my first slide, if that's visible to you. With no further ado, the next slide, rapid review, is a central part of what I'll be addressing today, and I'm going to begin by providing just a quick orientation, hopefully something that looks very familiar to members of the committee. I proceeded in overly great haste, and I'll try to avoid that in the future. Please allow me to pause now to note that I'm speaking with you today from my family's home in beautiful North Vancouver, British Columbia, which is also unceded territory of Coast Salish peoples. Returning now, if I may, to the slides. The scope of the review that we are undertaking, and that I'll be providing an interim report on as part of my remarks, is outlined here. It has a few clauses, and as I'd mentioned, I hope these are familiar to members of the committee. There are a couple of slight modifications to the mandate in order to provide us with what I hope is an appropriate refinement. So the first clause under definition of safe supply is the provision of pharmaceutical agents. The second clause is about the population of interest, and it is to people who are addicted to or dependent on these substances and who are at high risk for poisoning or other adverse outcomes. And third, which is also related to the nature of the intervention, these agents would be provided for unwitnessed consumption if the individual wished, and via their preferred route of administration. The outcomes of particular interest are listed below. So safe supply in relation to fatal, non-fatal overdoses, more generally the health or safety of individuals or communities, and a couple of examples, crime or drug diversion, are listed there, and then any other potential benefits. Next slide, please. With that definitional point addressed, the outline of my remarks is as follows. I'll make reference to some of the early framing of opioid prescribing and programs for the treatment of addiction, followed by the emergence of two separate systems of care. I'll move on to describe why British Columbia is an important and relevant exemplar for understanding safe supply and its emergence, an interim review of the results of our investigation of safe supply, and then a few related perspectives for your consideration drawn from addiction research. Next, please. I'd like to introduce, as part of the context for my presentation, a couple of home truths from the field of addiction. This relatively simple-looking figure was introduced as definitional of harm reduction, or part of the definition of harm reduction. You can see that there are really two main components, one above the other. And one is the volume of substance consumed, and below is the related but not entirely synonymous aspect of risk, where excessive use is associated with more risk, abstinence the lowest possible risk. And harm reduction is movement to the right. It does not require abstinence, and it does not require any particular form of intervention. Seatbelts in the 1970s were harm reduction for driving. In the future, with self-driving automobiles that have near-perfect safety records, seatbelts may no longer be necessary as means of reducing harm. Similarly, supervised consumption sites are essential in settings where there are numbers of people living homeless and using drugs. But if one is committed to providing housing and support for individuals, then the relative need for services like consumption sites decreases. The other point I'd like to make here is that the subjective achievement of recovery from addiction emerged as an area of research after harm reduction, but it can be superimposed on this figure. Individuals experience recovery. That is, they are fundamentally no longer experiencing addicted. It's a qualitative state. It's defined best by the individual themselves. And the likelihood that recovery is synonymous with abstinence is higher when an individual's addiction was very severe. However, it is abundantly clear from literature that individuals experience recovery from addiction without necessarily achieving abstinence. And so I'll mention that by way of background. Next slide, please. This is now an observation that the source here is more than 20 years old. The observation is far more than 20 years old, that individuals recover from alcohol and drug problems, including addictions, without necessarily encountering treatment. And in fact, this is a common occurrence. You may be able to see from the title of the article that the context for this is a social context. The authors are pointing out the role of social capital. That's a multi-faceted concept, social capital. Subsequent to this paper, some people working in the area have reframed social capital as recovery capital, intending to shine a spotlight on the facets of social capital that contribute most to recovery. But for our purposes, I think social capital conveys the central idea effectively. And when individuals have relatively more relevant social capital, recovery is more readily attainable. And when people don't, investing in shoring up their social capital is typically prerequisite to assisting them in overcoming their addictions. Next slide, please. These figures represent at the bottom in the lower left all of the individuals represented in this figure, drawn from a population level analysis. All of the individuals in the lower left are dependent or experiencing addiction with respect to these differing substances: nicotine, alcohol, cannabis, and cocaine. As the lines ascend, the proportion of each group that continues to experience addiction decreases. At the very top of the figure, a score of 1 would mean no one in the original group any longer experiences addiction. From left to right is the march of time, measured in decades, 10, 20, 30, et cetera. And it's clear from this figure that differing substances typically require differing periods of time before people are likely to experience recovery from addiction or no longer meet criteria for dependence. Nicotine and, cannabis and cocaine tend to attenuate more quickly. Those problems tend to resolve more quickly. You can see that the majority of people are no longer dependent after 10 years, while alcohol and nicotine attenuate over longer periods of time. Paired with the previous observation about social capital and its contributions to recovery, we can superimpose on this thoughts about early in life, recognizing that almost all forms of dependence begin early in adulthood or in adolescence. And so by the time 10 years has passed, we can imagine we're looking commonly at people in their 20s, assuming adult responsibilities, entering relationships, and moving forward in ways that are no longer consistent with use of drugs like cannabis and cocaine over longer periods of time. Alcohol and nicotine dependence attenuate. They have less severe impacts on daily functioning, and nevertheless attenuate as people experience things like health consequences, accidents or arrests involving impaired driving, the birth of children, grandchildren, and other types of catalysts, which people typically reference as key motivators for their cessation of use or the end of their addiction. Next slide, please. I mentioned in my outline the importance of BC. This slide is developed from Senate materials from Canada's Senate in 1955, and as you can see, a tallying of individuals referred to as addicted. They're presented in different categories, reflecting the origins of addiction, having first been prevalent among professionals, that being medical professionals, physicians, pharmacists, people with access to opioids and other drugs. The medical addicts are the individuals, and forgive I'm simply using the same terminology as the slide here, but the medical category are individuals whose addiction is deemed to be a product of prescribing. So these would be patients typically, and the left column, so-called criminal addicts, is the one that exploded in numbers in the middle part of the last century, in particular following the Second World War. You can see here BC has by far the highest numbers of so-called criminal addicts, not necessarily the most medical or professional, but those numbers are dwarfed by those deemed to be criminal. This emergence, the phenomenon of the growth of this particular problem, was a catalyst for immediate reforms, which then are the legacy that we've inherited today, and in some ways are trying to remedy. Next slide, please. I mentioned the catalytic role. This was in the late 1950s. Clinical researchers in both Canada and the U.S. were funded by their respective governments to attempt to intervene in the lives of people deemed to be criminal and addicted. The thinking behind the intervention is summarized here. This is the definition of rehabilitation. These are quotes taken entirely from the researchers' presentation of findings. The results of these programs were reported as extremely successful. You'll see from these few slides. Importantly, the role of medication or and methadone in this context was as an inducement and as a transitional aid into treatment, whereas rehabilitation is defined as activities in the social world, almost foreshadowing what we subsequently came to refer to as social capital or recovery capital. Next slide, please. The aim being to free the individual from dependency, but these changes in the social world often being essential to achieve first, my comments on social capital, and the cardinal principle being patience and the persistent provision of support to individuals. Next slide, please. The Canadian research is eclipsed in the literature for its influence by the work of these researchers, in particular Marie Neiswander and her husband, Vincent Dole. And you can see from this headline in JAMA, they are out of the gate reporting a blockbuster success. They're reporting this is the abstract, 94% success, ending criminal activity. And what was that due to? Next slide, please. They report the remarkable achievement of social productivity, stable employment, responsible behavior. They go on to say this, of course, cannot be attributed to the medication, which merely blocks drug hunger. They go on to explain that the achievement of this social productivity, something that the Portuguese described as social reintegration, was achieved through the interactions between their patients and humans that provided them with the supports and pathways forward in order to make a success of their lives in these various domains. Next slide, please. The catalyst for these early methadone programs I referred to, there was a subsequent catalyst for the expansion of so-called narcotic addiction treatment arising in the, coinciding with the reporting of these findings. And one of the major catalysts, especially a US catalyst, was the specter of some 20,000 returning servicemen addicted to heroin. Very careful research and fascinating research covering this phenomenon. The cutting to the chase, very few and almost none of the returning servicemen required any form of treatment in order to overcome their addiction. They described it was not because they didn't have access to heroin or something of that nature. It was that the lives that they were returning to were inherently of greater value to them than continuing to use heroin. Next slide, please. Nevertheless, this era was the largest single expansion in spending on addiction treatment in North American history, certainly in US history, a tenfold increase. Next slide, please. Those original authors, Dole and Neiswander, commented extremely critically on the rollout of narcotic addiction treatment bearing the name of their intervention, methadone maintenance treatment. And in particular, they pointed out, first of all, that it's not that the programs are no longer attracting individuals who are in need of help. And the reason they are not is that they overemphasize, as they describe it, a chemical agent, and that the chemical agent can have very little effect on transforming people's lives. They go on to describe, in terms that I think we can understand quite easily, the kinds of things that are much more urgently needed and yet were not provided and remain conspicuous in their absence from methadone treatment today. Next slide, please. Confirmation of the harm that we all experience as a result of losing the plot and focusing on biochemical interventions as opposed to human ones is illustrated here. The likelihood of overdose mortality, or more correctly, poisoning mortality, is powerfully related to unemployment. When people are employed and absent from work, their likelihood of poisoning is comparatively low, but unemployment is second only to disability, which is also coincident typically with underemployment or unemployment in this population. Next slide, please. Going from the individual level, if we look at areas where people are living, there is a high correspondence between communities which are deemed to be socially deprived and the likelihood of both opioid prescribing and poisoning mortality. Next slide, please. Our work in BC illustrates that rather than being an inducement into a program of social reintegration, people receiving methadone here are enrolled an average of 8 years, during which they commit ongoing numbers of both nonviolent and violent offenses, the opposite of Dolan Niswander's findings. Next slide, please. We have, on the left, we have increasing between 2008 and 2017, sharp increases in the numbers of people who are involuntarily admitted to hospital in BC, where the primary reason is substance use disorder, that rising from 1887 to 4536. Next slide. During the same period of time, we have sharply increasing proportions of people in our correctional institutions. This is provincial custody. And the lines are illustrating the increasing proportions of people who are held in custody and who have been diagnosed with substance use disorder, with or without a mental disorder, prior to entering custody. And in the most recent year, 2017, available to us, it's 70% of the custody population. Next slide. Importantly, the overlap, which I alluded to briefly with mental illness, is substantial, and several studies, this is one of them, are now reporting the high degree of suicidality among people who survive poisonings, and referring to their state of mind at the time that they experience the poisoning episode. The likelihood of experiencing suicidal intent increases with the number of prior poisonings. Next slide. Social capital, if I may. This one is illustrating that one of those groups that I showed early on, so-called medical addicts, professional addicts, this being physicians, that physicians are assisted in overcoming addictions through programs that emphasize social and psychological supports framed around the social capital that they have retained during their addictions, and without any opioid substitution therapy. It's almost the complement of what people in the public system receive, which is an opioid substitution therapy and very little, if any, support with things like work, improved housing, and social reintegration. Next slide. I mentioned Portugal's national drug strategy. I draw your attention only to the lower of the two quotes, which is drawn from their guidance document, that strictly speaking, there is no such thing as treatment, as they define it, without social reintegration. Next slide. We do have high quality studies that build the opportunities for social reintegration. This is actually a cost effectiveness paper based on several randomized controlled trials, and this is an intervention known variously as recovery-oriented housing, also synonymously harm reduction housing. If you recall the line figure that I began with, those two terms are interchangeable in the sense that a focus on persistently reducing harms is likely to improve individuals' opportunities to experience recovery. This is an intervention that costs about $38,000 a year, by the way. Next slide. This is how people describe their experiences in these interventions and give some insight into the journey people who have been homeless. Individuals in this trial have been homeless for an average of 10 years, struggling with serious mental illnesses and addictions. And here we see in their words, how their experience of support contributes and lays a foundation to their opportunities to recover from both addiction and mental illness. Next slide. This intervention has been shown to, it's highly robust. It works across Canada. It's been replicated in 4 cities in France, also using randomized controlled trials. It reduces reoffending by about 50% in the first year compared to usual care. Next slide. It also reduces emergency department visits by about the same amount, 50%. And this is using administrative data. So I'm not reporting things based on people's self-report, but on our surveillance systems in BC. Next slide, please. Now I'm sort of tipping by referring to study quality, I'd like to briefly introduce that there is an occasionally debated, but nevertheless widely respected concept of levels of evidence. And as background to our review of literature addressing safe supply, we're following this relatively traditional outline which prioritizes reviews of randomized controlled trials, interventions where people are assigned a chance to receive one of 2 interventions. This gives us the highest degree of confidence that if there are differences between the 2 groups, it's due to the intervention and not other things. Followed by individual randomized controlled trials, or it's possible to do to basically emulate a randomized trial, but without true randomization. Lower would be case control studies or retrospective cohorts, where at least there is a comparison, case reports, and then last reasoning. The note added here by the Oxford Center for Evidence-Based Medicine is that any individual study could be graded down in relation to a research question if it doesn't align with the purpose of the review, in our case, this review of safe supply, based on things like the population that's included, the intervention that's tried, or other things. We framed our review around the population as described in my first slide, drawn from your mandate, drawn from the committee's mandate, the intervention, safe supply, as it was defined. And we entered these search terms into the Medline search engine. And next slide, our results were, we identified 839 articles. There were no systematic reviews or randomized controlled trials. There were a total of 18 articles that reported original research findings and discussed safe supply. Of the 18, 16 were conducted in Canada, 13 in BC. I mentioned the importance of BC earlier. This is another reminder of that. Findings were based on either interviews or questionnaires. The interviews were often were typically with relatively small samples. 9 did not offer a definition of safe supply, and none were designed to examine the outcomes of interest listed on that earlier slide using any kind of objective measure, such as administrative data, the kind of data that I referred to in relation to the reductions in crime and reductions in emergency department visits associated with housing, or any comparison group. Next slide, please. The results of the papers did show, these are the most common themes reported in the results of the papers that we identified, a high prevalence of homelessness, often over 90% in the study sample, a high prevalence of unemployment, near 100% in some of the studies, high prevalence of food insecurity. And these are all factors strongly implicated in both the causes of addiction and by addressing them with reductions in harm and promotion of priority. Only one of the papers reviewed out of 18 focused on addressing these factors as an important implication of their results. All of the others overlooked them and instead, next slide, prioritized safe supply, even though safe supply per se was typically undefined and not related to their study results. So these are a few, the top two are examples from BC and Canadian authors drawing a connection between their findings and as implications for safe supply. Only one article, which happened to be from Indonesia, interpreted their results in an opposing way and said that instead it was important to focus on factors that influence the quality of life of the people rather than safe drug use supplies. Next slide, please. There is a difference of basic root causes between those that appear to be advocating for safe supply. That is that the cause of the...
Sorry, Dr. Summers, that's the end of the 30 minutes, but if it's the will of the committee, I would like to put another 5 minutes on the clock so you can finish your last 3 slides. Any concerns? Agreed. Perfect. Thank you, Dr. Summers.
Thank you, Mr. Chair. So a difference of root causes, and from the perspective, and I'm offering this in an effort to make sense of the of this quite peculiar set of studies. It appears that the ability to overlook, or the shared tendency to overlook social factors as causal is may be motivated by the interpretation that addiction in the population of interest to us and of concern to us is caused by the supply of toxic molecules. This is an unusual, very much against the grain view in the area of addiction, where much more, well, overwhelmingly, addictions are understood to be influenced, and I've used this language of supply and demand, that the demand for addiction is created by isolation in these domains, by estrangement from society, by the absence of meaning in life. Among Indigenous colleagues, I often am reminded that this is interpreted as experienced as the loss of all relations, or more succinctly still, the loss of connection. Next slide, please. The overlooking of social determinants of addiction or social causes is one aspect of this. There are other features that are also overlooked and in advocating for safe supply, and that are important to emphasize. One is the known side effects of prescribing. These the top 2 studies, you won't be able to read this perhaps, but they come from over 20 years ago. The lower one from 2019 is a systematic review and meta-analysis, high quality evidence, emphasizing harms associated with long-term prescribing, and in this case focusing on markedly heightened sensitivity to pain. Next, please, next slide. Other consequences, or implications, I should say, of advocacy for safe supply include the demand placed on, in this case, Alberta's provincial formulary. Drug shortages are widely acknowledged across Canada, and one area that is particularly worrisome is our shortages involving anesthetics. Fentanyl is one of the most important anesthetics, is referenced specifically in this particular paper, where specialists in anesthesia report that these shortages result in them providing inferior anesthetics, using medications that they're not familiar with, and it must be considered what the diversion of a drug like fentanyl into other areas would have, the implications it would have for surgical planning and alternatives. This is not an elastic commodity, as I'm sure members of the committee are aware. Last slide, please. As we've been conducting our review, we became aware of the completion of some work by the group jointly led by Stanford University and the Lancet Medical Journal. This review emphasizes the importance of commercial and profit interests in the perpetuation of the opioid crisis, advocates strongly for changes, but also touches on some of the issues of interest to our review and I think to the committee, emphasizing that policies that should attract skepticism include dispensing drugs from vending machines and prescribing potent opioids and other drugs to individuals with opiate use disorder in hopes of creating a safe, addictive drug supply. The authors might have, I'm glad they didn't, but they might have simply reframed this as policies that should attract skepticism are those espoused by people from British Columbia, which is very much the epicenter of this particular type of advice. And as I've said, I'm glad they chose not to frame their review that way. So let me adjourn there and thank you again for the additional time.
Thank you, Dr. Summers, for your presentation. We're now going to open up for question and answered with the members, and we will do that until 10:15 a.m. And we're going to start with MLA Rosen.
Thank you, Doctor. I have a series of 5 quick questions for you. They shouldn't take too long. I'm just wondering if you can confirm that last statement you had that said policies that should attract skepticism include those that include the dispensing of what would be considered a safe supply drugs system. Can you just confirm what the source of that study was, please? Oh, you're on mute.
Quite right. The source is the Lancet Commission.
Thank you. And you had another definition of rehabilitation, and that definition was to detoxify addictions and addicts and teach them to function in society without the aid of drugs. Can you also just confirm one more time on the record what that source was?
The main source was Dole, Neiswander, and Warner. From the Journal of the American Medical Association in, I believe it's 1968.
Thank you. You had some statistics about the likelihood to overdose of those who are employed versus unemployed. Can you just confirm one more time for us as well how significantly the likelihood to overdose increases in individuals who are unemployed compared to those who are employed?
So among people who have been diagnosed with opiate use disorder, unemployment in this study increased the odds of poisoning by, I believe it was about 6 times. And is an insight into the larger unemployment is also related to a higher likelihood of suicidality, and the onset of employment and support in employment leads in the opposite direction.
Thank you. And do you have any data that would suggest how many people who are using safe supply drug provision are employed full-time or at least on a part-time consistent basis versus those who would use safe supply who would not be consistently employed?
Well, we found no papers reporting on the delivery of safe supply as we have defined it based on the committee's mandate. If we're looking at, I can draw reference to other studies where drugs like heroin, for example, are prescribed to people. This is on an experimental basis, coming to clinic 3 times a day. In that Canadian research, if I'm not mistaken, over 90% of the patients were unemployed at every time point where they were measured.
Thank you. And my last question then is, do you have any data to suggest how many of those who are reliant on safe supply, or if we don't have papers on safe supply for opioids, I suppose, potentially prescription heroin, any data to show how many of those reliant on prescription heroin or opioids go on to get clean and who use that prescription basis as the springboard that gets them clean and rehabilitated as the definition from before?
In North America, in particular, very few, if any. In the Ontario methadone program, for instance, for every additional year that a woman is receiving methadone, there's a 7% increase in the likelihoods of being convicted of a crime. For men, it stays constant. It's referred to by many clients, patients, as a form of chemical handcuffs, and I think that's an apt metaphor.
Perfect. Thank you. That's all my questions.
Excellent. Thank you, member. We have MLA Yao up next.
Dr. Summers, thank you again for taking the time to speak with us and as we study this very serious issue. As you went through the slides, I couldn't help notice there's a certain parallel to Maslow's hierarchy. And for the general audience that's watching, all 100 people, Maslow's hierarchy is a study on how humans partake in behavioral motivation. And the first step being physiological. If you have things like food and clothing, then you can focus on things like safety, which are job security and housing. And when you have that, then you can focus more on love and belonging, which are your social needs and friendship. Eventually getting to the pinnacles of working on self-esteem and ultimately self-actualization. Is it safe to say a lot of what you were explaining there really reflects Maslow's hierarchy? That, for example, you focused on housing first there, that if we can address the housing needs of a lot of the folks that have these addiction issues, that they'll be in a better place to address their addiction issues. Is that fair to say?
Yes. Yep. It is. I think a lot of what has come to pass in the field of addiction validates Abe's observations about motivation, and in particular that if we are, if in the case of those trials that I referred to, the part of Housing First that has really been unsuccessfully translated into practice is an emphasis on individuals' own choices and supporting their, in using more psychological terms, their sense of agency. And when we are able to emphasize people's agency, like a choice of places to live, for instance, which is how we'd, as opposed to here's your place, a choice of places, and providing people with choices and the supports to stand by their choices and learn from them, is the surest path to that we know of to assist people overcoming their mental illness symptoms, their addiction struggles, and is entirely consistent with the way that Maslow described the progression that you summarized.
Follow up? Yes, sir. And just to clarify, again, you studied systems like what happened in Portugal, who are considered leaders in addictions and whatnot, treatments. And you mentioned that they emphasize the fact that treatment requires social reintegration. So is that fair to say again, that's, under Maslow's hierarchy, that is like the social needs, the friendship under love and biology, belonging, that, again, if we're addressing the physiological issues, the safety issues, the love and belonging, and that they can start to focus on the self-esteem and ultimately the self-actualization, and that that is what other nations have identified, again, that are consistent with what you've just said, that if we address all those issues beforehand, housing, their safety, their shelter, that, as well as love and whatnot, that they're in a better place to fight these addictions. Yes?
Yes, absolutely. That and reinforced by that, as I point out, the high prevalence of suicidal intent and suicidal thoughts. The best response we have to help people transcend that kind of state of despair involves the same elements that that we're emphasizing or that are emphasized in helping people overcome addictions. It is summarized as establishing lives that are worth living.
Thank you, sir.
Excellent. Thank you, member. We next have MLA Milliken.
Sure. Thank you, Dr. Summers, for being here today. I recognize that the purposes of your presentation today is to essentially go over a review of the literature as what is already out there. I guess one of my questions, I'm struggling a little bit in the sense that what I'm getting from this presentation, I believe, is that it would be fair to say that there isn't too much high quality evidential-based research out there as currently dealing with safe supply. Is that a fair assessment?
Yeah.
Both for or against. So I'm not even looking at it from the perspective of whether or not it's a good thing or a bad thing. What I'm looking for potentially is whether or not there's, essentially what you're saying is, as of right now, the literature out there is lacking.
It is lacking with respect to safe supply, as the term is being used today. So that is leading to evidence supporting the increased prescribing of drugs, as your committee has provided by way of example, as a means of reducing harms in the population. There is a lot of evidence that is not using the term safe supply that demonstrates the likely harmfulness of implementing activity as safe supply is defined here. And that's what led the Lancet Commission to their conclusion that this is one of the recommendations to be skeptical of. So there is in our review, we were searching for evidence where the authors are presenting findings and are then recommending an increase in prescribing. What we found in that 839 tranche of papers was that most of the authors that used the term safe supply were using it in relation to reduced prescribing. We did not include those papers because that's not the sense of the term as the committee is using it. But there is if we had searched for literature on evidence to support reduced prescribing, harms of prescribing, side effects of drugs, we would be overwhelmed. And it's that source of literature, as I said, that is being referenced in the Lancet Commission's overall interpretation that this is not a credible pathway to reducing suffering as against others where there is much stronger evidence.
Thanks. And just as a quick follow-up, it would be my expectation that individuals either for or against safe supply as defined with regards to this this committee would be rushing to create evidence-based resources to rely on. Do you know of any ongoing studies that may be happening?
Yes, there have been. We've come across, for example, descriptions of studies that have been published. So they're not presenting results yet. They're outlining the protocols that they are planning to follow in order to generate findings. I'd hasten to add that when deployed among people who are homeless, unemployed, suicidal, living with serious mental illnesses, and in states of despair, it is at least perplexing why investigators would choose to focus on leaving those aspects of people's lives untouched, when they are directly implicated in the likelihood of recovery, and instead focusing on the marginal gains that may be achievable by prescribing drugs to them while they remain in those abject states of poverty and despair.
Thanks. You have a follow-up, member? Good. Okay. Thank you, Doctor. We now have MLA Amory up.
Morning, Dr. Summers, and thank you very much for this incredibly informative presentation that you've provided. I think all of us committee members are in debt to you for your time and your expertise in this area. Doctor, this committee is, as you know, tasked with examining several aspects of safe supply, including whether there is any evidence that a proposed safe supply would have an impact on fatal or non-fatal overdose, drug diversion, or associated health and community impacts. This is a broad and general question because I think that all of us committee members are here to learn as much as we can about this particular issue. And so with that in mind, is there any evidence that access to a safe supply of opioids, heroin, crystal meth, cocaine, or other substances, for example, for people who are addicted to or dependent on these substances, reduce the likelihood of suffering a fatal or a non-fatal overdose?
There's no direct evidence because I am not aware of any government or oversight body making drugs like cocaine or crystal meth available to people, whether they are addicted or not. And the evidence of the relationship between more prescribing or more availability of drugs and harms is massive. There is an extremely strong correlation witnessed most recently in the so-called oxycodone era and that crisis. There's no direct evidence for the reasons that I've described. It would simply be illegal on an international scale, and I think that suppresses governments' willingness to sort of buck international treaties and do things like prescribing crystal meth or making them available to people. But it would go against all of the known evidence relating to harms of drugs. And also, as I've mentioned, form a very kind of perplexing opportunity cost. Why? I don't know how many, if any of your staff have done a back of napkin estimate of what it would cost to provide fentanyl to individuals on an annual basis. Our sketch is that it would very quickly, for fentanyl alone, go past 6 figures. And while people remain homeless and nobody's helping them with their employment, we're ignoring reconciliation and the project of reconciliation as a contributor to reduce addiction. So why ignore all those things, given cost-effectiveness trials showing that interventions that cost a fraction of that amount are highly effective at supporting people in their ascent of Maslow's hierarchy, and instead prioritize something that is completely contraindicated by available evidence. It smacks of interests that go beyond those of the health of the individuals that we're attempting to support.
I'll take one more follow-up. Thank you, Dr. Summers, once again. Now, my colleagues here early this morning have brought up some various examples of jurisdictions, if you will, that have applied or are attempting to apply a sort of safe supply model. My colleague Taniel brought up the example of Portugal earlier today in his question, and we have one model of proposed safe supply here in Canada, at least in BC as one form of what they might purport to suggest is a safe supply model. I understand that the evidence suggests from your answer here and the answers prior to today that there is sufficient evidence that exists, independent, credible evidence for harms of prescribing or reduced prescribing, if you will. You also mentioned that there is credible evidence that suggests that prescribing or safe supply does not achieve its intended purpose. I'm wondering if you can comment on whether or not you have any information to provide this committee with respect to how the jurisdictions that are implementing these policies, or how the jurisdictions that are contemplating these approaches, justify the introduction of safe supply and or reduced prescribing practices, and indicate that it is a correct path given the evidence that you're bringing up here and saying, given the evidence that you're suggesting is overwhelmingly in favor of not proceeding towards this type of practice?
Well, there in BC, where I call home, there is a long-standing disinterest in addressing social determinants of addiction. When I brought up at the beginning of the public health emergency, and back when I was still invited to meetings here, I brought up the glaring, to me, involvement of the absence of reconciliation with Indigenous peoples as a contributor to their overrepresentation among decedents, our abysmal record of transitioning from institutional to community-based care for mental illness as a means of explaining the overrepresentation of people with mental illness among those who are at risk. The increasing numbers of youth who are displaced from housing and means of supporting themselves economically. And there was an absolute disinterest in considering any further examination of risk factors in the social world as it contributes to the risk of poisoning. The emphasis was on that's an equal opportunity risk, and the only viable means of addressing it is by prescribing medications and getting people connected to the provincial formulary. It was entirely a supply-oriented focus. I think people, frankly, have their heads in the sand and perhaps are intimidated by the scale of addressing these social determinants. But other experiences, such as that of Portugal, emphasize, as do almost all of the successful treatment studies, including those that I've referred to today, all show that successfully overcoming addictions is achievable and is achieved best by promoting social reintegration, using familiar structures to all of us participating today: work, home, family, meaningful elements of life. Portugal's turnaround came without anything like safe supply. They used methadone, consistent with the studies that I referred to earlier, and on a far more important level, involved housing and support. In fact, they emphasized housing to such a degree that even though they were addressing homelessness and poisoning fatalities, they did not need to introduce a single consumption site, normally something that would be a stock in trade when a large population of homeless individuals are using drugs. They were able to bypass the need for a consumption site because they prioritized rapid rehousing of individuals along with other forms of support that enabled them to be self-sufficient.
Excellent. Next we have MLA Stefan.
Great. Thank you so much for your presentation. One of the arguments that I think, at least that I've heard in favor of safe supply, and I'd be interested in your response, is that some would assert that but for providing safe supply, individuals would die because they would be taking tainted drugs. I know that would be a common argument. I'm just wondering what you would say in response to that argument, that but for safe supply, individuals will access tainted drugs that will cause them to die.
Yeah. So keeping in mind, this highly speculative environment in which this so-called safe supply is being described. I mean, the term itself is sort of it obscures, I think, the meaning of what we're describing. But if we were to, we proceed with individuals, let's say, as I've alluded to, experiencing homelessness, social exclusion, joblessness, friendlessness, really and often a lifelong lack of support. About a quarter of the people that we've worked with meeting those criteria were also in experience severe adverse childhood events. And so this is a lifelong pattern. And now we have a choice, we and you have a choice. We could approach that person at immediate risk, as you've described, and say, based on randomized controlled trial results and cost effectiveness results at about $38,000 a year, we could say, today, I have some options of housing available that we could go and look at this afternoon, and to be followed by support obtaining employment. 80% plus of the people that we meet and interview in this dynamic say that on the day we meet them, that they want to pursue paid employment, and about 60% have worked for at least 1 year consecutively in the past. They have it in their repertoire. So we can approach people for that relatively small cost with these types of choices, and yes, support in using drugs more safely, reducing harms, proceeding in the direction toward recovery, one small step at a time. We could do that today. Invest in people, show them that we believe that they have more to achieve in life and that they have worth. Or for an as yet uncalculated but vastly greater sum of money, we could approach someone and say, I can see quite clearly that you're suffering psychologically. I can see quite clearly that you're suffering due to exposure and a lack of place to live. I'm going to not talk to you about those things. I'm going to ignore them as though they're somehow insoluble. Instead, how would you like a free supply of the drugs that you're taking addictively? I'll do that. Now, what kind of message is that to the person? Yes, it would be arguably better than nothing, but through that very act, we're confirming their perceived worthlessness, that this is the best we can do, when in fact we can do much better, and people in need of assistance consistently say they want more. People are not asking, when they're seeking help, they're not asking for a safe supply of drugs. A large Scottish study of people seeking help with their opioid and polysubstance addictions reported that over 50% were seeking help primarily to get off drugs, and that less than 2% were seeking help using drugs more safely. So this is not something that has a grassroots component to it. It is something that is being somehow introduced from outside.
Thank you, member. Did you have a follow-up? Mr.
Yes,
Staff?
please. Thank
Yes, sir.
Yes, please. Thank you. So I appreciate the distinction between recovery and harm reduction type of discussion there. Would you say, just to kind of clarify in terms of literature and the concept of safe supply, would you say there's a distinction between using prescriptions to wean people off drugs for the purposes of recovering from addictions versus prescribing to protect individuals in their addictions from tainted drugs? In terms of the search of literature and the discussion of safe supply, is there a distinction there between, again, prescribing as a means to move people off being addicted And perhaps my understanding is methadone, I think, sometimes is used for that purpose. I stand to be corrected there. Versus prescribing people with clean, I guess, drugs that aren't tainted, but not really used for the purposes of moving people off addictions towards recovery. Could you comment on that, those two differences in terms of safe supply?
Yeah, as yet there is no literature on prescribing drugs like crystal meth and cocaine to individuals, so there is nothing on that side of the ledger in response to your question, and there are many good reasons why proceeding in that direction would be potentially injurious to the recipients, to patients. Our physiology doesn't know where the molecules came from, and individuals who are using drugs in combinations are at high risk, regardless of where they get their drugs from. Receiving prescription drugs is no assurance that individuals would no longer be purchasing additional drugs and using them. We have evidence that about 50% of the people receiving methadone in our work with those experiencing homelessness and mental illness, 50% are using illicit drugs at the same time every day. So there's very little reason to believe that individuals, that first of all, that this project would be successful at displacing use of illicitly procured drugs. And it, as I've said a couple of times now, it is simply bewildering that that form of intervention would be prioritized above others that have far more evidence of effectiveness and would simply also be cheaper.
Thank you, Doctor. Thank you, Member. Next up, we have MLA Milliken.
Thank you for the opportunity to ask another question here. In jurisdictions where safe supply is being provided, and by that I mean in regards to ensuring or trying to ensure that people who are taking these drugs aren't getting tainted drugs, which of course I think the line of logic would then lead to an increase in overdoses. Do you know or did you find in your research any studies or study that shows safe supply is associated with harm reduction both to users and or the community, or I guess on top of that, whether or not it's associated with a decrease in overdose deaths in those jurisdictions?
No.
Excellent. That was quick. Thank you. Yeah. Any other members? We have about 2 minutes left for questions. Any other questions? Okay. MLA Yao.
I guess I'm wondering if, Dr. Summers, if you could sum up your presentation for us here as in a general, are you able to do that?
Sure, yeah.
Thank you.
Thank you, yes. There is a large volume of evidence bearing on how best to assist people who are at greatest risk of poisoning. And the pathway that has the highest evidence and a large volume of evidence focuses on, I'll put it this way, events in the social world, things in our social world, things outside of our skin, interactions with other people, opportunities, and we've discussed a number of them here today. Individuals struggling with inadequate housing or homelessness, with an absence of employment opportunities, and thereby an absence of means to support themselves, to be reintegrated in society. Those activities should be prioritized. Alternatively, the focus on safe supply, as we've seen in the papers we've reviewed, despite measuring these types of obvious social deficiencies in people's lives, chooses not to prioritize them at all, and instead focuses on an intervention that would only work, if it was to work, by having some effect within our skin, by changing somehow the individual's experience of drugs, risk of drugs. And there is simply no evidence that drugs on their own, as mentioned by Dole and Neiswander, that a mere chemical agent is capable of contributing to a meaningful change. So the upshot of this presentation, and I think of experience in the field of addiction, especially over the last 50 years, emphasizes that individuals are highly capable of change, far more so than we usually give people credit for, and that their ability to pursue change is a function of the social opportunities that are made available to them and the support to take full advantage of those social opportunities. So I commend to the committee to consider examining those kinds of approaches that would emphasize social capital and to have a sense of belief in the capabilities of the we're trying to assist.
I hate, there you go. That sounded like a conclusion. Thank you, Dr. Summers. Sorry, I was going to interrupt you, but it sounded like we that was good timing. So thank you for that. Thank you for your presentation, and to the Center for Applied Research in Mental Health and Addictions at Simon Fraser University for preparing this evidence review for us, and really appreciate your time with that. So thank you. We are actually going to take a short break, and we are going to reconvene back here at 10:20 for our next presenter. So thank you. present, and then we'll open it for question and answer.
Sure, if we can start with my presentation, if you're able to put it up. Thanks. I won't be looking at the camera because it's hard to see in gallery view. I'm going to be presenting on safe supply. I want to have you guys understand the relationship between the opioid overdose epidemic and opioid prescribing, understand why opioid overdoses decreased in 2018 in the US and 2019 in Canada, be able to critically examine the evidence for safe supply, and understand the facts and assumptions regarding safe supply. So if we can move to the next slide. Next slide. Next slide. So we're going to start with a little bit of history. Arthur Sackler was a Madison Avenue ad agent. He started the Terramycin campaign in 1951. This was a direct-to-physician advertising campaign, and he made so much money off of this that him and his brothers bought Purdue Pharmaceuticals. If we can move to the next slide. In 1980, Jane Porter and Herschel Jick wrote a 5-line letter to the editor in the New England Journal of Medicine saying that addiction is rare and less than 1% with people prescribed narcotics. However, this was only with people who were in hospital. They didn't follow them up after hospital. This became lionized as an extensive study in Scientific American and a landmark study in Time magazine. This was quoted over 1,300 times by other scientific papers. If we can move to the next slide. In 1996, the American Pain Society president, Dr. James Campbell, said in his presentation to the American Pain Society, if pain were assessed with the same zeal as other vital signs, it would have a much better chance of being treated properly. We need to train doctors and nurses to treat pain as a vital sign. Also in 1996, OxyContin was released by Purdue Pharmaceuticals with the same techniques that Arthur Sackler used in the Terramycin campaign, quoting the 5-line letter to the editor by Porter and Jick. So what happened after this? We can move to the next slide. So this is a graph of overdose deaths in Ontario between 1991 and 2015. I'd like everybody to follow the red line. The red line is the number of overdose deaths with OxyContin. The next line that I want you guys to look at is the dark blue line. So after a while, OxyContin became replaced by fentanyl, and the number of fentanyl overdoses increased. If we can move to the next slide. This slide shows the relationship between the amount of opioid prescriptions and the number of prescription opioid overdose deaths. As opioid prescriptions increase, the number of opioid overdose deaths increased. We can move to the next slide. So roughly 21 to 29% of patients prescribed opioids for chronic pain misuse them. Between 8 to 12% develop an opioid use disorder. An estimated 4 to 6% who misuse prescription opioids transition to heroin. About 80% of the people who use heroin first misuse prescription opioids. So the take-home point from this is most people who use opioids do not start with heroin or fentanyl. They start with prescription opioids. And this is illustrated in the next slide. So one of the fundamental issues is that you have two groups of people. One group of people uses prescription opioids. One group of people uses illicit opioids, and there's an overlap in between. However, every year, 4% to 6% of the people who use prescription opioids transition over to illicit opioids. And when we increase the amount of opioids in the population, we have an increase of opioid use disorder. We can move to the next slide. So this was opioid overdose death rates in British Columbia. And what you'll notice is that there was a dramatic decrease in 2019. Why did this happen? We can move to the next slide. So we're going to focus on this part in 2019 in BC. But moving to the next slide, we're going to focus on 2018 in the United States. So this is from the New York Times, and it talked about how the total drug overdose deaths in America declined by around 5% last year, meaning 2018, the first drop since 1990. The decline was mostly entirely due to a dip in deaths from prescription opioid painkillers. Fatal overdoses and other drugs, particularly fentanyl and methamphetamine, continue to rise. So there was a decrease in opioid overdose deaths by decreasing the number of prescription opioids. Now, what happened in 2019 in British Columbia? We can move to the next slide. There was a decrease in medications such as opioids and benzodiazepines that can cause overdose. The next slide. There was an increase in the amount of take-home naloxone that was handed out. The next slide. There were safe injection sites. So these were very localized. They weren't providing the drugs, but this was a safe place for people to use. And the next slide. There was an increase in opioid agonist therapy prescribing. So all of these four factors, if we can move to the next slide. All of these four factors contribute to the decrease in overdoses in British Columbia in 2019. So we're going to go over the evidence for safe supply. If we can move to the next slide. So this is the statistics that are mostly touted by the people who are talking about the evidence for safe supply. So between March 27th and August 31st, 2020, 2,780 people received the risk mitigation, aka safe supply medications. Of the 2,780 people, 10 people died, leaving a mortality rate of less than 0.4%. So one big factor here is that half the people were prescribed opioids, about a quarter were stimulants, about a fifth were prescribed alcohol withdrawal management medications, and it's unclear why this was included in safe supply, and 12% were prescribed benzodiazepines. So if we can move to the next slide. So 0.4% mortality rate sounds like a good number, but if we break it down to the population level, how many people have an opioid use disorder? How many people have an alcohol use disorder? How many people have a stimulant use disorder? How many people have a sedative use disorder? So if you add all of that up and take the number of overdoses in 2017, the base rate of overdose death is 0.2%. So the rate of 0.4% that's touted in their study occurred over 4 months. So it was, over 5 months. So it wasn't even 1 year. So you could expect that mortality rate to increase over a period of a year. The other thing that they don't reveal is what percentage of people in their 0.4% were on opioid agonist therapy. There were no comparison groups, and there were no objective measures to see if people were using less fentanyl. So this 0.4% that they're touting is actually higher than the base rate of overdose death in the population in British Columbia. So why do we need objective measures? If we can move to the next slide. There was a study in the Journal of the American Medical Association in 2012, and this followed, I think it was about 8,000 people over 6 years. And what they found was that high patient satisfaction was related to lower emergency department visits, but greater inpatient use, higher overall healthcare and prescription drug expenditures, and increased mortality. So the higher the patient satisfaction, the more people died. And this is why we can't rely on patient self-report to evaluate this program. We need to look at objective measures. So I'm going to go over some of the facts and assumptions regarding safe supply. If we can move to the next slide. So increasing the amount of prescription opioids available has known harms. It increases the amount of opioid overdose deaths, and it increases the amount of people with opioid use disorder. The benefits of safe supply are unknown. If we can move to the next slide. So proponents will say patients are looking for safer alternatives and consistent dosing for the substance of choice. We do not know if safer supply reduces overdose. The assumption is patients will use hydromorphone instead of fentanyl. So one possible outcome is the assumption is true and patients want hydromorphone instead of fentanyl. Another outcome is that it does not decrease fentanyl use and hydromorphone is used in addition to fentanyl. Another outcome is patients may sell safe supply to get more fentanyl. Another outcome is safe supply can be diverted, creating more addiction in the population. And another outcome is patients may use safe supply in harmful ways, causing more harm, like crushing and injecting tablets, leading to infections, vasculitis, and lung diseases. Any evaluation of the program would need to consider all of these outcomes. If we can move to the next slide. Proponents will say we are forcing patients into restricted treatment modalities when they are not ready for addiction treatment. So the assumption is that this approach will be beneficial for patient. So one possible outcome is the assumption is true and safe supply will keep patients alive. Another possible outcome is safe supply may increase risk of death for patients prescribed it, increasing exposure to opioids, increasing access to fentanyl through diversion. Another possible outcome is overall death rates may increase as more people become addicted to diverted opioids and stimulants. Any evaluation of the program would need to consider all these possible outcomes. And we'll go to my last slide. So this was from a CDC article, and this was someone who uses drugs and was prescribed safe supply. And he was saying that some days he doesn't take the pills, which is why a stockpile is building up in the supportive housing unit he lives in. Quote, maybe more than half of the people that I know
Sorry, Doctor, that
who are on
was,
these are looking to sell them.
sorry, Doctor, that was 10 minutes, but I see you got one slide, so
Sure.
maybe if you can wrap up. Thank you.
Yep, it was just finishing that quote. So there is a large amount of diversion taking place, but no one is evaluating the amount of diversion.
Thank you, Doctor. That was a lot of information to cram into 10 minutes, so we appreciate your efforts. No, thank you for that. And I will now open it up for 20 minutes of question and answer with the members. Is there a member that would like to start? MLA Rosen.
Okay, thank you for the presentation. You mentioned the amount of people who are prescribed opioids, or I'm wondering if we can break that number down a bit. So for the people who are prescribed opioids, what percentage of those people develop an opioid use disorder?
So this is for chronic pain. And so between 8 to 12% of the people who are prescribed opioids will develop an opioid use disorder. So opioids are one of the top medications that are prescribed, and so a large amount of people are developing an opioid use disorder.
Okay, thank you. And then what percentage of people who misuse their prescription opioids transition to heroin after being prescribed?
So 4 to 6% of the people who misuse or who are prescribed opioids will transition to heroin. So this is the worry with Safe Supply, is that we're going to increase the amount of people addicted to prescription opioids, and then every year 4 to 6% of them will go and transition to illicit opioids, and that's the danger. We hear from patient groups that they don't like hydromorphone, they don't like the safer alternatives to opioids. Recently in Vancouver, I'm not sure if you guys are following the news there, they were handing out crystal meth, cocaine, and heroin. And they had people who use drugs rate them on a 5-point scale. And they were mentioning, people were rating the cocaine and the methamphetamine 4 out of 5, but they had much lower scores for the heroin. And the reason is people are used to taking fentanyl. They're used to taking illicit fentanyl. This is what is demanded in the drug market at this point in time. So it's unlikely that if we prescribe them these other opioids, that they're going to use them instead of fentanyl for recreational use.
Okay, and so you brought me to my next question, which is if 4 to 6% of people transition every year to heroin from the prescription opioids, at this moment in history, do you know how many people who are currently using heroin, or what percentage of people currently using illicit heroin started with prescription opioids?
80%.
Thank you. Just 2 more questions. You mentioned in the past, or I'm not sure what year it was, but there was a decrease in the number of prescription opioids prescribed, and that resulted in a decrease in deaths from opioid overdose. I'm wondering if you can just give us the numbers one more time on how much the prescriptions decreased by, and as a result, how much the deaths decreased by.
I have a graph showing how much it's decreasing by. So for opioids, it went from around 800 prescriptions in mid-2015, and then this dropped to about 550 prescriptions by July 2017. So there's been a reduction in time with opioid prescribing. And what I'm worried about is that we have made some gains by decreasing the amount of opioids that are prescribed in society, and we might reverse these gains by prescribing more opioids than we've ever prescribed.
Okay, and my final question is, you mentioned that the mortality rates amongst those who begin with prescription opioids or those who are using a safe supply system are higher than those who are not using such a system. I'm just wondering if you can tell us quite how much higher or how large that difference is between the mortality rates of the 2 systems.
So what they're using for evidence for safe supply, so this was the 2,780 patients, the mortality rate was 0.4% in 5 months. The base rate mortality is 0.2% in a full year. So the thing that they're using to tout as safe supply is working, I don't think shows the data that they think it's showing.
Just to be clear, the mortality rate was twice as high in a short period of 5 months as the baseline mortality rate.
It is. However, I mean, there has to be some caveats to that in that the people who are prescribed safe supply tend to be sicker, but they're not measuring any of this, and there's not objective outcomes to see if people are using less fentanyl. Uh, and I don't really understand why they aren't using things like urine drug screens to see if people are using less fentanyl once they go on to safe supply. What they're essentially doing is that they're asking patients, is this program working for you? What are the benefits? And then they take that at face value, which really isn't how a lot of medical interventions are studied.
Yao.
Thank you, Chair. Dr. Matthew, thank you so much for taking the time to speak with us and our committee as we study this very serious issue. I have a few points I just would like you to reflect on and provide your answers to, but based on your presentation, there's a high number of people that become addicted to opioids and whatnot due to prescriptions. That said, these prescriptions are reflective of a inherent safe supply, I guess, we have already out in the system. Is that fair to say? And then how are our physicians in Canada educated in addictions? To what level? And are they at a level where they are recognizing these issues around prescription addictions to the prescriptions that they distribute? And do they work on weaning the patients off of these opioid potential addictions, if you will, on that? That's my first questions.
So there's a lot to unpack there. I was wondering if you can say the first question over again, that this comes from an inherent safe supply. I didn't understand the question.
A lot of the addictions seem to come from people who start off with prescribed medications from physicians. Say they have a hip surgery, they're waiting like 2 years to get that hip surgery because our system is pretty slow here in Canada, and they get addicted to those prescriptions. Is it safe to say that, technically speaking, there already is a safe supply out there? It's what we prescribe to our patients for their pain relief.
I think that's absolutely correct. Most of the people who use illicit opioids, so 80%, started with prescription opioids. And so there's two groups. There's people that these are directly prescribed to who become addicted, and then some of those people divert the medications and they're sold in the population. So when you increase the amount of prescription opioids in a population, you increase the amount of addiction to opioids, and you increase the amount of addiction overdose deaths.
My second part to that question was, are our physicians here in Canada, you work out of British Columbia, is that correct?
Yes.
Are our physicians in Canada educated to the point where they understand the opioid issues and are and part of their treatment programs for their patients are weaning them off these very same opioids that they prescribe, or is that somewhat questionable?
To be honest, I can't speak to the rest of Canada. I know for myself, I've given a lot of lectures to physicians and residents, and it is part of the psychiatry training program at University of British Columbia. I don't know what's happening with the rest of the training. However, the College of Physicians and Surgeons of British Columbia also has a standard of practice that physicians must follow. So there's been a lot of education about this, but I couldn't speak to the rest of Canada regarding this topic.
Thank you. My second question is, follow-up, Chair, is you had some slides there that talk about patient satisfaction, but that does equal a higher mortality rate. So is it safe, are we basically saying that if we're just simply to rely on the patients who are addicted to these medications, that if we can't necessarily rely on their satisfaction and saying that they need to maintain these opioids, because ultimately it does lead to an increase in a higher mortality rate? And the reason why I asked this question is some of the groups that withdrew from our discussions here, our consultation process, that those are their arguments, that these people would have, their loved ones would have survived had they just simply had access to clean drugs.
So I think it's even broader than the question that you're asking. In general, in medicine, when you look at medical interventions, you cannot rely on just patient self-report. You have to look at objective measures of benefit. This is why we have allopathic medicine and we don't have homeopathic medicine in Canada. The reason is we have randomized controlled trials. So if you look at the experience of human disease, most people that have diseases in general, like the broad experience of disease, will get better by themselves. So most people, their experience of disease would be the flu or things like that. So when you have an intervention, you have to compare a group that doesn't get the intervention to a group that does, because a lot of people who don't get the intervention will get better. So you have to see whether your intervention is better than the placebo group. Does that make sense?
Yes, sir.
Excellent. We now have Emily Amory.
Good morning, and thank you, Dr. Matthew, for your time and your presentations here today. I want to go back a little bit to some of the information that you provided in your slide deck. I know that 10 minutes is barely enough time to scratch the surface in this incredibly important area, and I wanted to kind of go back and have you highlight some of the things that you wanted to bring up in your presentation. Now, you've already illustrated that the relationship between opioid prescribing and overdose deaths are directly related. And that is, when we saw the chart that you had presented earlier, we saw where opioid prescribing increases, we see an almost corresponding increase in the total overdose deaths. I understand that overdose deaths is one factor for consideration. It's a metric that a lot of people place an incredible emphasis on, and I think for good reason. But I also think that there are other issues that we need to talk about as well. To be clear, I don't want to, for a moment, suggest that overdose deaths are not an incredibly important factor and the ultimate tragedy, if you will, but there are other impacts that I think we need to talk about, some of which you alluded to in your presentation. Now, the idea, perhaps, Doctor, is that safe supply reduces deaths, and I'm not sure in particular where the evidence lies in relation to that metric. But I want to know what other impacts we are seeing, and in particular in BC, where this safe supply model is being implemented. I think it's the best example that we have in Canada of a safe supply or quasi-safe supply model, and really the best jurisdiction that we can compare to other Canadian provinces for more information. Now, what we're seeing, I think, in your slideshow and in the key assumptions that you highlighted is that overdose deaths are not the only impact that we're seeing as a result of safe supply. Can you describe for the committee whether the evidence is settled that, in fact, overdose deaths are decreasing in safe supply jurisdictions like BC? And similarly, I want to give you an opportunity to comment on what trends and impacts that BC is currently experiencing that you may not have had a full opportunity to comment on during your slide presentation.
It's a very large question, and I'll try to unpack it the best I can. There is the issue with overdose deaths, but there's also the issue with addictions. So we had a case where there was a girl who was going to UBC who had gastric surgery. She was prescribed hydromorphone, became addicted to the hydromorphone, started buying the readily available hydromorphone, and overdosed several times, showed up at Vancouver General Hospital. And when she got to hospital, instead of starting her on treatment, they discharged her with a prescription of safe supply hydromorphone. And they kept doing this, and she kept overdosing. Eventually, she met up with a colleague of mine, and he started her on Suboxone. And she said that she would have started on Suboxone earlier if safe supply wasn't available. So one of the issues is that you can increase the amount of addiction in the population. And this has negative effects on healthcare costs. This has negative effects on the people of British Columbia. And we need to somehow try to look to see what the impact of it is. Because with safe supply, we have to look at things like overdose deaths. We need to look at the things of impact of addiction overall and the healthcare costs available to that. And we need to see what the net result of all of these issues are. But there doesn't seem to be any sort of search to see what the net effect is and what the net effect of diverted safe supply medications are in the population with a possible increase in addiction.
Thank you, Dr. Matthew. I'm going to yield my follow-up to another colleague who has a question for you.
Excellent. Thank you, Emily. We now have Emily Steffen.
Sure. Thank you for that presentation. I thought it was excellent. I wanted to just, near the end of your presentation, it seemed that you had talked about how safe supply is sometimes used perhaps in inappropriate ways. In that, I know sometimes I've heard, my understanding is that individuals suffering under drug addictions are really looking for the next high. They're trying to get that high, and that the potency of safe supply is sometimes not good enough for what they are seeking, and that sometimes they'll use the safe supply that they're provided for purposes of a type of currency to get drugs that they think will get them that high, or they'll use the safe supply in a more intense way to try and again seek the potency that will give them that desired high that they're looking for. Can you comment in terms of studies of the use of safe supply as currency, for example, to get perhaps non-prescribed drugs, or when safe supply is used beyond the way in which it is prescribed or intended by the user of it?
So there aren't great studies on this. I did write a case study of a person who was convicted of fentanyl and methamphetamine distribution in the downtown east side. And he was talking about what happened before Safe Supply came in and COVID and what happened before. So one of the metrics that I found interesting was that he said the street price of hydromorphone tablets was $10. So an 8 milligram hydromorphone tablet was $10 before Safe Supply went in. At the time of the interview with him, which was in August 2020, the price of hydromorphone tablets had decreased to $2 a tablet. More recently, so within the last 6 months, it's dropped down to 25 cents a tablet. So now you can get 4 tablets for $1. So if people were consuming the safe supply that they were being prescribed, there would not be a drop in the street price of hydromorphone. With a hydromorphone being more available and cheaper, it gives more opportunity for people to use this for non-medical use and become addicted to hydromorphone over time. Some of the benefits of safe supply are sometimes when people are in withdrawal, they might take some of the safe supply to stave off withdrawal so that they can get so they can stave off the effects of withdrawal. But oftentimes what happens is people who are using safe supply don't feel that it's strong enough, and then they will sell their tablets for currency to get more fentanyl. The other thing is when they are using safe supply, they might not use it in tablet form. They might crush it and inject it, and that can cause a lot of issues with infections and other injection site issues.
Milken with about 2 minutes left. Sorry. Oh, sorry. Member Steffen, did you have a follow-up?
Yeah, very quick one. I'm just wondering, what's the BC government's response to the fact that there is this street price dramatic fall in safe supply medications? Because that sounds very serious to me.
To be honest, I don't really follow politics a lot, so I don't know what the response is.
Excellent. MLA Milliken, 2 minutes left.
Sure, I'll just ask very, very quickly then. Do you know of any studies that show that safe supply is associated with better outcomes, such as recovery for opioid users?
Not in the model that we have in British Columbia. So some of the things that they might cite are injectable opioid agonist therapy treatments that are found in places like Switzerland. But the problem is with the Swiss model, you do have injectable opioid agonist therapy, but you also have a lot of societal interventions, such as their 4 pillars model that includes treatment, harm reduction, law enforcement. So what they've done is they've taken that medication and they've taken it outside of the Swiss model, and they're just looking at the medication alone. And so we don't have evidence for that. The other issue is, the other example is John Marks. So he was a physician in Merseyside in the United Kingdom, in Manchester, and he prescribed heroin and cocaine in the 80s. None of his what he was doing was not studied. There aren't published studies on this. However, it's very different than the safe supply model that they have in British Columbia, because in that model, they had the psychiatrist, they had a social worker, and they had the probation officer for the patient. And the patient would have to convince these three people every week that these medications were benefiting them. So we actually don't have.
Thank you, Dr. Matthew. That does conclude our time for question and answer. And on behalf of the committee, sincerely thank you for taking the time and for preparing the presentation and delivering it. So we really appreciate your time, and hope you have a great day. You're welcome to join us to listen in on the rest of the presentations. I'd now like to invite Dr. Madras to join us today. And Dr. Madras, thank you for being here. We're going to open up for 10 minutes of presentation, followed by 20 minutes of Q&A with the members. Thank you, Doctor. I hand it over to you.
Thank you very much. Can you hear and see me?
Yes, we can.
Wonderful. I can't see myself. So I thank the distinguished members of this special committee for the opportunity to appear before you today to discuss safe supply. I'd like to preface my remarks by saying your responsibility is grave, the stakes are very high, and the decisions you make in this session may echo for generations to come as they reach nearly every domain of life in the province. It's a decision that should not be hurried, because it is, in fact, a social experiment of vast multi-generational implications. It is also a human experiment without really informed consent, because the evidence in terms of randomized controlled trials, meta-analyses, reviews is zero, as pointed out so aptly by Dr. Summers. The endpoints may be ambiguous, they may be grievous, or they may terminate with remorse. So the Canadian government has decided that tainted drug supply is the core part of a response to the opioid overdose crisis. And I'd like to emphasize the fact that if it were not for opioid overdose deaths that have catalyzed so much government intervention, we would not have these hearings anywhere in the country, because addiction has been festering in both the United States and Canada for decades without too much government concern as to its consequences. It is only because of the deaths, and justifiably so to some extent, that this has happened. The really important issue is to discuss opioids. I understand completely the inclusion of psychostimulants as well as other classes of drugs, but opioids are a unique class which may not have been highlighted by Dr. Summers, inasmuch as if treated with behavioral therapies or what have you, the dropout rate is well over 80%. Opioids are really quite a unique class of drugs because it is one of the toughest addictions to deal with. And aging out is relatively common for alcoholism, for smoking, and for some of the other drugs. But aging out is far rarer with opioid addiction. We also have to highlight the fact that opioids have different types of biological effects, one of which, if it's a full agonist, such as methadone, such as fentanyl, such as heroin, will promote a full-blown effect in the brain, except that certain drugs, like methadone, do not promote the highs and lows that other types of opioids do, such as heroin and fentanyl. Buprenorphine is another medication which has been approved for treatment, and it too does not promote the highs and lows that one gets with full agonists, which can be achieved by misusing prescription opioids such as hydrocodone or oxycodone derivatives. So I've been asked to proffer my opinion. It is based on 4 roles which I've been engaged in as a research scientist in public policy and as a member of the President's Opioid Commission, as an educator. My 4th role is that of a protagonist, a Cassandra, a person who tries to predict the future. And I'm going to focus today on a broad view of public health policy. The science that backs this up would consume many hours and probably about 120 slides. So what is the underlying reason? The underlying reason for safe supply is that it assumes that the government's responsibility is to provide pharmaceutical-grade substances with high abuse liability, with addictive potential, with adverse consequences to people with a substance use disorder. The alleged purpose is to prevent overdose deaths due to fentanyl contamination, to prevent overdose deaths due to unregulated quantities, and to prevent health effects due to contamination of the supply with fillers and toxic substances. So I make 4 points, and I would like to pose 4 questions to you. And of course, I'm open to questions from everyone. Will increased access to pristine drugs increase use? Our current and historical examples support that they will increase use. We can look at the history of tobacco to alcohol, marijuana, prescription opioids, fentanyl, cocaine, methamphetamine. Price and purity govern supply. Providing free drugs will reduce the perception of harm. And as you reduce the perception of harm, you increase use. And this has been throughout many of our national surveys starting from the 1970s. We will also see increased aversion as we've witnessed with prescription opioids. So the question is, does this committee have any evidence that supplying safe drugs will stabilize or decrease use and substance use disorders? The prescription opioid disaster catalyzed in the US is a paradigm of how increased supply of pristine opioids resulted in increased misuse, diversion. At some point, more than 70% of the people misusing opioids received them from friends, family, either bought or just taken or stolen. So as use will rise amongst youth and young adults, which are the most vulnerable population. The second question is, will increased use of pharmaceutical grade drugs ultimately have negative impact on overdose deaths, diversion, and so on? The focus on drug purity sidesteps a critical factor. Alcohol, tobacco, opioids are manufactured to pristine quality, yet they kill more people annually than other illicit drugs combined. Access is easy, use is normalized, the patterns of use, and that's the key issue, is the uncontrollable use by the user. Does this committee have evidence that safe supply has increased entry into treatment more effectively than improving access to treatment, drug courts, or other means of treatment entry? Regulating the purity of a drug and its dose omits a critical element of this problem. You cannot regulate whether or not people use a safe supply safely. How much, how often, what drug combinations people use. Substance use, the very definition is defined as uncontrollable drug use despite adverse consequences. Unless recovery and abstinence are the goals, regardless of drug purity, addiction will continue to take its toll on people from in utero to old age. The impact will continue to be negative regardless of the quality of the drug. Prescription opioids, again, I've done a very, very in-depth survey of how we got into this problem when I wrote a majority report of the President's Commission on the Opioid Crisis, is perfect example of how increased access and normalization for any pain indication increased misuse, addiction, overdose, and deaths. The third issue is increased access. Will it increase risks to individuals? The term safe is asymmetric, as I've said, and refers not only to supply, but it has to refer to safe use. And the emphasis on recovery has to be critical. Does this committee have evidence that safe supply will be used as an incentive to motivate people into treatment and recovery? And is there any other benefits or consequences of safe supply? Does this committee have evidence that safe supply will be limited to pristine heroin, cocaine, crystal meth, which is not even it's not even a prescription formulation currently, and fentanyl? Or will subpopulations demand new psychoactive substances that appeal to them? New stimulants based on cathinone analogs, pyrovalerone analogs, new opioids. Are physicians willing to prescribe these drugs, including fentanyl, as they're currently doing in British Columbia? Will you regulate the use? There are thousands of potential new substances that are coming on the market that may rise to fashionable use as fentanyl has, and what will happen then? I can give you reams and reams of data and experiences over this. But in summary, my testimony does not address optimistic predictions. I would just like to do my narrative addresses the very important disconnect between safe supply and safe use. Based on the preponderance of historical and current evidence, I do not believe Alberta should take this step.
Thank you, Dr. Madras, for that presentation. And we're now going to open it up for question and answer with the, even though we've already done the question stuff, so hopefully we'll get some answers too. And we'll start with MLA Fry. MLA?
Hi, Dr. Madras. Thank you so much for your presentation. I was really intrigued by when you were talking about, I think your quote was, as you reduce the perception of harm, you will increase usage. So I'm wondering if you could relate that to, I know there's a conversation around a lot of political circles about decriminalization of things like opioids and harmful drugs that we know are also very addictive. So would you think the same phenomenon could happen through a decriminalization lens? If governments start to normalize the use of illicit substances, do you think that could also lead to more usage and pressure on healthcare systems?
Well, we already have seen it. We have certainly seen it, certainly in Canada and in the United States with regard to marijuana, which is legal now in Canada. It has been decriminalized in most states in the United States. And what we've seen is a vast increase in use, a rapid increase, not only in use, but in cannabis use disorder. From 2016 to 2019, we had 900,000 more people with cannabis use disorder in the United States. And we're seeing all the consequences associated with it. Perception of harm of marijuana has declined dramatically in the US amongst youth. And that's a very good example of normalizing use, increasing access, decriminalizing, and seeing that perception of harm has declined quite dramatically. Now, that is not true for certain other substances such as tobacco, which the use rates are declining, even though it's easily accessible. The tobacco products are relatively pristine, but there has been a very massive campaign to denormalize smoking in the country because of its health consequences, not because of its psychoactive effects. And as a consequence of that, use has declined amongst youth. And more youth are not using alcohol and tobacco now than ever before. So it is possible to legalize drugs and to decrease use, but the bar is extremely high, and we're going to lose a generation while we figure out how to promote prevention for specific types of drugs. because tobacco prevention has been around for almost 40 and plus years. Alcohol ads and prevention has been around for as longer, not longer.
Oh, I certainly appreciate that. Mr. Chair, do you mind if I have a follow-up?
Yes.
Thank you. So,
I mean, I don't mind.
my so I guess my follow-up question would be to Dr. Madras again. How would you describe your qualifications for being able to speak to this committee? I know we're looking at the list. I know you have many letters behind your name here. We know that you're qualified, but for the people of Alberta who are listening in on this, can you please give us a little bit of background, or how you arrive at some of the high quality medical evidence that you give to this committee, and what perspective you're speaking from?
Well, I speak from a basic science perspective. I certainly can describe to the public as well as to my colleagues how drugs affect the brain in terms of the molecular, cellular biology, anatomical effects, behavioral effects, and so on, because that's been core to my entire career. But secondly, with regard to public policy, I was confirmed unanimously by the United States Senate to be the deputy drug czar of the United States between 2006 and 2008. And during that period and prior to, I had been studying the social, the psychological, the treatment modalities for substance use disorders quite extensively, because I organized the first and only course at Harvard Medical School at the time on addiction biology and addiction consequences and treatment. The course ran for 15 years, and during that time, it was a very extensive learning experience for me, because I always partnered with addiction treatment specialists and visited many treatment centers, sought treatment withdrawal centers. During the time that I was the deputy drug czar, I visited multiple treatment facilities around the country. Above all, I listened to people who were suffering with addiction, and listened to their families, and listened to their stories, and listened to how systems are failing them. And so I did an extensive program to try to catalyze screening and brief interventions for people who are not who are along the full spectrum of substance use, and managed to accomplish a number of goals during the tenure I was in Washington. Fast forward a decade, and the president appointed me on the Opioid Commission along with 5 other people, 3 governors, an attorney general, and a former congressman, Patrick Kennedy. And the chairman of the committee, Governor Chris Christie, asked me to essentially to shepherd the entire commission report. And in doing so, I summoned the expertise of all my friends and colleagues, as well as my own experiences, and likely composed between 65 and 68% of the commission report, using a number of resources, including my home base, which has addiction treatment specialists as well. So I've been in this field since the 1960s, when I was a graduate student, and I was the heir of the CIA LSD experiments. The LSD was given to me without my knowledge of what the source was, the origin, or its human use, and I was asked to study how it works at the Allen Memorial Institute in Montreal. And since that time, my commitment to understanding how drugs affect the brain at the molecular, cellular, and so on level has gone unwavering for the past 60 years. I was a graduate student at the age of 20 there.
Thank you, Doctor. MLA Yao.
Thank you so much, Chair. And again, Dr. Madras, thank you so much for taking the time to speak with us. We greatly appreciate that. You're probably very busy at Harvard Medical School right now. I have 3 points I'd just like you to expand on, if possible. Just the first point is, you mentioned something along the lines of this is a social experiment and that there's zero evidence ultimately on this issue. The second point I'm asking you about is you mentioned aging out. And if you could provide a definition of what that means, and you talked about how the aging out is different for opioids compared to things like ETOH and, alcohol and caffeine and whatnot. If you could expand on that. And the third is, you make a good point that we cannot regulate whether people will use a safe supply safely. So is it fair to say that despite access to safe supply of a pharmaceutical, that we will still have deaths? And I guess we could compare that to acetaminophen, which is a very safe supply that's available in any drugstore, yet one could argue that's one of the most lethal medications out there readily available for people because of its destructive abilities on our livers. If you could expand on those three comments, I'd greatly appreciate it.
Sure. I wonder if you could just repeat the first question, because with pre-pulse inhibition, I was listening to question 2 and 3 too carefully.
No problem. The first one was, I thought I heard you mention that this is a social experiment and that there's ultimately zero evidence on this.
Yes. So basically, as your first speaker mentioned so eloquently, there is no real good solid data on whether or not you can administer cocaine or methamphetamine or amphetamine or any of the other substances, and what the long-term outcomes are going to be in that population. There may be short-term gains, but take, for example, the prescription opioid crisis that was catalyzed in the United States. At the time that it began to be ramped up, and there are at least 33 causes of the opioid crisis that catalyzed this problem. At the time that they ramped up, we had zero information on whether or not it is safe to prescribe opioids for longer than 3 months. And yet, the pharmaceutical industry, the patient population, certain, like the Joint Commission, the Federation of State Medical Boards, the Veterans Administration, a number of other organizations began to promote pain as the 5th vital sign and the absolute need to use opioids for these chronic conditions such as lower back pain, such as knee pain, and without evidence on what would happen over the long term, without evidence on whether or not they were even necessary. And what we have found recently, because the field was compelled to do the studies, is that NSAIDs, non-steroidal anti-inflammatory medications, are just as effective as opioids for the most common causes of pain. And chronic administration of pain of opioids after even 7 days puts the individual at risk for very prolonged use, because the opioids promote neuroadaptation in the brain that appears to be durable and, in fact, drives continued ongoing use. So I think that's really important. We don't have good, solid, high-quality evidence on whether or not safe supply is going to work. We have had studies in the country on trying to treat people with fixed doses of methamphetamine or amphetamine in clinical trials. They've all failed. I can tell you that or methylphenidate. None of them have because I was very much involved in medications development for quite a while. The second issue, the same question, was aging out. And the aging out is a well-known phenomenon. People quit smoking. A very high proportion of people who, when they're given warnings about smoking, quit. And most of them quit cold turkey without going to rehab or going to a treatment center. With alcoholism, if it's not severe, if they do not have a number of other confounding factors, psychiatric problems, social problems, and so on, and genetic disposition. Many people can quit heavy alcohol use, problematic use, or even alcoholism without an intervention. So but opioids, the quit rate is very, very low compared to these other drugs. And so I think that pretty much answers the question on and safe supply. If anybody can point me to high quality research, I would be very willing to listen to it. From the best of my research on looking at the literature, it just does not exist.
Member, did you have a follow-up?
No, that's fine.
Okay. Perfect. MLA Rosen.
Thank you so much for being here. I have a couple of questions. Most of them will focus on statistics, so should be quite quick. As MLA Fry mentioned, you quoted that clean drugs reduce the perception of harm, which increases the use of the drugs, which I found to be such a profoundly simple but logical and straightforward statement. So I'm wondering if there is any data from the United States that suggests just how much the use of drugs increases in jurisdictions that provide quote unquote clean drugs.
Well, I think the easiest data is just looking at Len Palauzi's work from the CDC, showing that as prescriptions of opioids increased, the number of overdose deaths increased almost in a perfect parallel line. And I think that by far the most profound example of what happens when you supply clean, pristine drugs to people is to look at the opioid crisis, because the data are overwhelming, they're abundant. Problematically, as of the last study that I have seen, about 65% of people who enter treatment for opioid addiction now did not begin with prescription opioids. That number was much, much higher in the early part of the opioid crisis. Now people are really initiating with fentanyl and heroin, and fentanyl is becoming the drug of choice. And in some places, heroin is not even available. It is only fentanyl and adulterated with cocaine or methamphetamine or prescription drugs or benzodiazepines. All that data, every one of the questions that you ask, I can provide citations for as a follow-up. I'd be delighted to do it.
I would love that if you could do that. I have another question then. On average, if we look at the death rate from opioids in the United States, what percentage of individuals who die from use of opioids die from tainted or drug poisoning versus just overuse in a normal overdose?
That's a very important question, which I don't think we have solid evidence that people, if only we could ask them post hoc. There have been studies done by one of my colleagues, Dr. Hilary Connery, at McLean Hospital, in which she has interviewed people who went through an overdose but actually survived. And they were asked what were their intentions in taking the drug. Lamentably, about 30% roughly, and I have to get the actual figures because I don't have them memorized, but approximately a third were actually intending to commit suicide. And the others were, what percentage of the rest were unaware that they had tainted supplies versus non. Those studies, there's actually been a couple of studies in the US on doing that. If I'm trying to remember the breakdown, but it's not inconsequential that people are aware that they want to use the fentanyl and are pushing the boundaries to get a greater high. The problem with fentanyl, as with certain other potent opioids, is that they produce rapid tolerance, which means you need to increase the dose in order to get the same effect. And people, self-report that they're always chasing that first high. They want to get back to the point at which they were introduced to the drug intravenously, and it gave them such a euphoric feeling that and they've developed tolerance to it, that they're still trying to increase the dose to achieve that same effect. So the answer is that I do believe there are some studies. I can excavate them for you. I don't have the proportions on hand, but I would say there is a significant but minority number of people who are actually using the drug with the view that they may die and are not in despair over it.
Okay, thank you. And if you could find those studies after the committee today, that would be wonderful. My last question is that you also made an interesting note that there has been a campaign against the use of tobacco by governments for decades. But interestingly, it seems as though governments in some jurisdictions are now almost campaigning for the use of illicit drugs and opioids. So I'm just wondering why you think there is a discrepancy there between the approach of governments towards tobacco versus illicit substances, and what or who is driving that?
Well, this is truly a political question, which I have many opinions on, because I have been very privy to a number of situations where I know what the pressures are with respect to pushing illicit opioids, or respect to pushing illicit drugs. I can say that, for example, with marijuana, there was no grassroots movement among the general population to legalize marijuana in various states. It was a heavily financed campaign involving hundreds of millions of dollars to going state by state to trying to understand how to carve ads and legal documents to shape it according to those state desires. Primarily starting by medicalizing, and after medicalizing, legalizing. We're seeing the same movement now for hallucinogens. We've seen it for marijuana, and I suspect we're going to see it for opioids in the future. Kevin Sabat, who follows me, is going to be probably a bit more forthcoming with regard to all these pressures. But needless to say, there are big industries now involved in vast investments. There are over 300 companies now that have invested in promoting hallucinogens. And we're going to see this movement. The only people standing in the way of this movement are legislators. You.
Thank you, Doctor. Thank you, Dr. Matters. Sorry to cut you off there. That concludes our time for question and answer today, and actually a nice transition to Dr. Sabat. So thank you again, Dr. Madras, for your presentation and joining us today. And thank you, Dr. Sabat, for being here. We're going to open up for 10 minutes of presentation for yourself, and then we're going to have a Q&A with our members. So I hand it over to you. Oh, Doctor, you're muted.
Great. Well, thank you, Chair and committee members. Thank you for inviting me. It's my pleasure to offer oral testimony today at the Select Special Committee to address safe supply in Alberta. I have studied, researched, written about drug policy and criminal justice policy for more than 25 years, having been the only drug policy political appointee in both Republican in the George W. Bush and Democratic in the William Jefferson Clinton and Barack Obama administrations. Most recently, from 2009 to 2011, I served in the Obama administration as a senior drug policy advisor to the director of that office. I am currently a fellow at the Institution for Social and Political Studies at Yale University and a co-founder and president with former Congressman Patrick J. Kennedy of SAM, Smart Approaches to Marijuana, a nonprofit public health organization dedicated to working with scientists and policymakers to advance evidence-based marijuana policy. My doctorate is in social policy from Oxford University and my undergraduate degree in political science and public policy from the University of California, Berkeley. Now, while safe supply is not an accepted medical term, I think it's really important to say that at the outset, that it is a marketing term designed to sell a policy. We in the United States do have lots of examples of physician-prescribed opioids and a long history of opioid proliferation and wide open supply. We have implemented a nearly analogous policy by allowing a supply of opioids to be prescribed via doctors and supplied by pharmaceutical companies. Today, I will share with you the experience of the United States and our version of safe supply of pharmaceutical drugs. Now, to start, it's important for some background. As we've talked about today, grimly, the Centers for Disease Control and Prevention announced recently that there were over 100,000 overdose deaths in the 12-month period ending in April 2021. And we just have new data coming out saying the same thing from other sources, marking an increase of about 30% from the 78,000 deaths during the same period the year before. Of these deaths, these 100,000 or so deaths, the CDC estimated that about 75% of them resulted from the overdoses of opioids, an increase of 35% from the previous year. Now, opioids ranging from prescription painkillers to heroin and synthetic drugs like the fentanyl class of drugs are now responsible for over 75% of overdose deaths. The CDC also found that overdose deaths involving opioids have increased over 6 times since 1999. The Department of Health and Human Services estimated 1.6 million Americans today have an opioid use disorder. And this is generally regarded as an undercount, both in those with an opioid use disorder and also our death count rate, because the data that we have to collect these are not as complete and comprehensive as we would like. In response to these alarming increases in deaths caused by opioids, the Trump administration, the previous administration, declared a public health emergency on October of 2017. Similarly, the Biden-Harris administration's White House of Drug Policy has called for an extension of the opioid public health emergency declarations. Policymakers are now taking steps to address the overprescription of licit, legal opioids, such as OxyContin, as well as confront the inflow of illicit opioids, such as those in the fentanyl class of drugs. But it's important to ask how we got here. Nature magazine, the renowned scientific magazine, has argued that it wasn't until the mid-1990s when pharmaceutical companies introduced opioid-based products, and in particular OxyContin, a sustained-release formulation of a decades-old medication called oxycodone, manufactured by Purdue Pharma, that such prescriptions surged and the use of opioids to treat chronic pain became widespread. In other words, these had been around for a very long time, but it wasn't until they were marketed as such, marketed as safe, and supplied in large amounts that this became a much bigger problem. The North Carolina Medical Journal published a study that found several factors that contribute to the over-reliance on opioids for the treatment of chronic pain. Starting in the late 1980s, the medical establishment came under fierce criticism from patient advocacy and other groups for undertreating both malignant and non-malignant pain. This became known as the movement to make pain a fifth vital sign. And in 2017, Medicare structured reimbursement to hospitals, up until then, I should say, we structured reimbursement to hospitals in part on how thoroughly pain was eliminated. So there was an incentive to treat pain and treat pain aggressively. As a result, opioid medications were heavily prescribed and physicians were incentivized to utilize them. And they were incentivized by multiple sources. They were incentivized by government, they were incentivized by business, they were incentivized by shadow groups. And it's very important to understand the influence of a lot of these groups that these groups have on the political system. Being in Canada right now, where I am currently, just in your neighbor province, I wish I could say that the influence of these groups was only confined to the United States, but I have witnessed the influence of these groups also here in our country of Canada. The most recently released National Drug Control Strategy, the one in the Biden-Harris administration, has stated that the overprescribing of drugs, the diversion of prescription drugs for non-medical use, and the lack of accountability or oversight in prescribing practices increase the availability of these drugs in America's homes and workplaces, making them far too easy to fall into the wrong hands. That is the word of President Biden's Drug Policy Office, and I agree with it wholeheartedly. As such, governmental agencies have been working to advance safe prescribing practices, which will try to ensure fewer pills are given to patients and that patients are fully aware of their risks of their medications. A study found, that, for example, that 61% of opioids prescribed following surgery were left over, which amounted to something like 275 milligrams hydrocodone. 27 5-milligram hydrocodone extra tablets per person. Assuming a maximum dose of 6 tablets per day, the average individual was left with enough medication to treat pain for an additional 5 days. Now, let's be clear. The majority of opioid addictions in America started with legal prescription pills found in medicine cabinets at home. In 2017, healthcare providers across the United States wrote almost 200 million prescriptions for opioid pain medications, which is about 60 prescriptions per 100 people, far outpacing the need for pain. NPR reported the oversupply of opioids floods communities with vast quantities of opioid medications that go unused, building up a deadly reservoir of drugs and home medicine cabinets that often wind up being abused. Now, there are many second and third order effects of the opioid epidemic that we often forget. For example, the recent U.S. Commission on Combating Synthetic Opioid Trafficking that RAND was a part of announced in their report that the current overdose crisis has cost the U.S. approximately $1 trillion annually in just the past few years. The costs include greater healthcare costs and lost productivity. In 2021, a study found the opioid epidemic is the primary reason for the reduction in the recent decline of U.S. life expectancy. And JAMA found that drug poisoning deaths contributed to a loss of about a quarter of a year in life expectancy. Most of this loss was unintentional. And so we've seen even effects on the labor force, which obviously is a huge issue right now. Alan Kruger, a professor at Princeton University, found labor force participation has fallen more in areas where more opioid pain medication is prescribed, causing the problem of depressed labor force participation and the opioid crisis to be intertwined. This is causing a huge strain on the foster care system. We rarely talk about the effects on families and children, but it's very important. In the past few years, the number of foster children nationally in the U.S. has risen by 10%. And the Department of Health and Human Services reported that many in the child welfare field think that parental substance abuse, including prescription drugs, illicit drugs, alcohol, marijuana, but especially opioids, has been the primary cause of the increase in foster care placements. There's studies finding that higher rates of overdose deaths and hospitalizations correspond with higher rates of child welfare caseloads. And in a report about the connections between the opioid epidemic and education outcomes, the Brookings Institution concluded that exposure to the opioid epidemic is likely to impact important education outcomes other than test scores, such as attendance, probability of school disciplinary action, graduation, or college enrollment. They also stated the opioid epidemic is a widespread societal problem, and we are only starting to understand the far-reaching consequences that will be borne by individuals and communities. So listen, the bottom line is that we have had experience with a flowing, regulated, medical, legal supply of opioids. And in the United States, it is not going well, and it has not ended well, and we don't think it will end well. I sincerely worry that by flooding willing users with more substances, our problem will be made much, much worse. And again, this goes back to what Dr. Madras and so many others have eloquently stated about availability and use. There are not many truisms in drug policy because this issue is one that is complex, context dependent, and really intertwined with so many issues. But one truism that most scholars agree on, most experts agree on, is that greater availability leads to greater problems because of greater use. Now, that isn't to say that there isn't a role for opioid medications in society. Of course there is. And we have to understand that, we don't want to go back to the other extreme of totally undertreating pain. And that pain is an issue that is important to deal with. But we have seen, it seems often in these policy debates, we want to go from one extreme to the other. And I find that regrettable. So thank you for allowing me to submit testimony today.
Thank you, Doctor, for your comments. We're now going to open up for Q&A with our members. And is there a member that would like to ask a question? Emily Yao.
Thank you so much, Chair. And Dr. Sabat, thank you so much for taking the time to speak with us. A very thorough presentation. Thank you for speaking in layman's terms for our general public. I guess to summarize your presentation, you've demonstrated that there is a lot of studies and evidence that contradict the concept of safe supply. Is that fair to say?
Absolutely. And really, it should not be seen as a partisan issue by any means. So this is something that everybody should be coming together on. We all want to see the reduced incidence of substance use disorder. We all want to see the reduced instances of problems in the foster care system and other systems. And nobody wants to leave anybody suffering that has a legitimate purpose to use certain medications. Now, as we've heard earlier, there are sometimes better medications that are less addictive that should be our first order. Because remember, a lot of these opioids were meant to be used in hospital settings under the strict supervision of physicians in really regulated environments, as opposed to sort of a wide open environment. And my concern with a wide open environment is that we are really opening ourselves up to more problems. And this is not a partisan concern. This is a public health and public safety concern.
Thank you so much for that.
No follow-up? All right, MLA Rosen.
Okay, thank you. I just have one question. I will ask you the same question that I asked Dr. Madras, because she said that you might have more of an answer for it coming from that political and research-based lens. But it's been noted, and I think it is interesting to compare the campaign that we've seen from governments against the tobacco industry and tobacco usage over the past couple decades, we will see, compared to the campaign almost for illicit drug use substance by the same governments. So I'm just wondering if you could touch on why you think that there is a difference in those two vastly different campaign tactics for substances that are both probably equally addictive, and who or what you think are driving those different campaign narratives.
Well, it's one of the great paradoxes of our time, to be honest, MLA. It is one of the great paradoxes of drug policy that we would say that we have learned and understand the harms of tobacco and nicotine that can be so severe, and they are. I mean, the legality and normalization of nicotine in North America has cost more than 650,000 lives annually, even now when we know what the harms are and when there's general agreement that we should not expand the use of that drug, of nicotine. And so we have general agreement that we shouldn't expand the use because it's harmful. And we've said that a way not to expand the use is to make sure that we have, heavy regulations, that we have a campaign of discouraging the use of that drug. Why would we turn around and say that rule does not apply to other classes of harmful drugs? Now, there is an important difference and caveat, because we know that there really is no accepted medical use for nicotine, whereas for some of these other drugs, there is accepted medical use. But that is a very fine line between accepted medical use of opioids and misuse and abuse and wide open supply of those drugs. And that latter scenario is what we embraced in the United States for a lot of some of the reasons I just superficially touched on. And it has put us in the position we're at now, because it's introducing a whole class of people as well to drugs that they may not normally have come into contact with. Because again, availability and normalization really does dictate and drive behavior. It doesn't mean that if drugs were legalized tomorrow, everyone in this room is going to go and try them because they're legal. No, but it does mean that certainly young people grow up in an environment of acceptance. And it means that if we have an inclination to try them, if we have an inclination to want to use them, it's much easier to get. Whereas with tobacco, we've said we want to make it harder to get. And so we placed all of these different controls on nicotine, and they've worked. Those controls have worked in terms of reducing public health impact and in terms of reducing initiation of use and reducing substance use disorder. So I do think it is a paradox that on the one hand, we want to approve of some drugs and not approve of others. Again, understanding with the small caveat that there is some accepted use, and no one is saying that we want to, outright prohibit the use. I don't think anybody on this committee, correct me if I'm wrong, is saying we want to outright prohibit the use of medically appropriate opioids used under the care of a competent physician, versus a one of these pain clinics like we had them in Florida or these other places that did not have legitimate medical supervision. So I think it is a great paradox. It's a great question.
Confirm with that paradox, I think it's safe to say that the campaign against tobacco and to reduce tobacco consumption has been primarily driven by the medical community. But would you say that the other side of that paradox, the drive to increase opioid use, has also been driven by the medical community, or would you say that has been driven by outside sources that go beyond the medical community?
Well, I think it's a lot of it is the latter, unfortunately. Look, now the medical community is certainly, at least in the United States 20 years ago, is partially responsible for the problem we have now because they were incentivized to prescribe, as I mentioned, and but they weren't always like that. They were pushed by companies and a government that went along with it and other private organizations funded by these industries that had an incentive to increase use. And so they were sort of the messenger in that. They were kind of a third order in that chain. Currently, what I see when I look at the global movement, and it is a global movement to legitimize and legalize all drugs. I mean, let's be very clear. It doesn't stop at cannabis. It's moving to opioids. It's now going to be moving to. We've heard a lot about stimulants and the issue of legalizing crack, cocaine, methamphetamine. It's sort of really all drugs. That is really not driven by the medical community at all. It's just like the push to legalize cannabis, both in Canada and the United States, was not pushed by the medical community. In fact, even today, the medical community in the United States generally opposes the full-scale federal legalization and commercialization of marijuana. So, I wish that there would be, the medical community would be driving more of these decisions, but unfortunately, I think they're driven by private parties with their own agendas, either agendas to sell, to sell these substances, which unfortunately we have seen. I mean, I couldn't believe it when I saw that there was actually companies in Canada that were ready to supply, quote unquote, safely these drugs to governments. And again, I think it's really born out of a feeling of helplessness and hopelessness as well by governments saying, you know what? Nothing's working. We don't know what to do. So we're just going to double down on, whatever the most influential interest group is saying and very loudly in our ears. And I have seen that, unfortunately, a little bit in BC, where, again, that's where I am right now. Here in BC, we see, I'm here temporarily, but we see, one of the worst opioid rates in the Western Hemisphere. And we hear more and more calls, I think, to double down on this idea that we should have drugs more available, not less available, not to get people treatment. And that is really what does worry me.
Thank you. MLA Stefan.
Thank you. I didn't get an opportunity to ask this question to our last speaker, but I'd like to ask it to you. And that is, I'm wondering if the term safe supply would be an oxymoron, in that the last speaker suggested that, or asserted that, clean drugs are still not safe drugs. So, So where did the term safe supply even originate? Do you know?
My understanding is that it was really a marketing term by advocates, because the terms are very important. And when you want to make political change, they're very important. And I got to hand it to them. It's a great term, but it's not a medical term. It's not great. It's great politically. And when I put that hat on, as I advised different political administrations, I think that's a great term. I think they did a great job in it, because it gives the impression that you can use drugs safely, that we should encourage the use of drugs, and that because we can do so safely. And to me, that's like saying, if we, teach people where to hold the steering wheel, and where they should be looking, then we should be okay with them going, 150 kilometers or 200 kilometers per hour on the highway, because most people who speed, they're not going to get into a car crash. So we could say that's generally safe. And so what do we need speed limits for? We don't need them. We can actually teach people how to do something that is inherently dangerous more, safely. And I think that's certainly the wrong way, really not helpful at all, because we know that before the fentanyl crisis, which we have, we know that there were still an unacceptable number of overdose deaths, number one. So the idea of a drug overdose didn't just happen when the fentanyls were introduced. And number two, we know that when you encourage the use of certain drugs, let's say a quote unquote clean heroin, you're also backhandedly encouraging the use of all other drugs as well. I mean, addiction is not something that's so neat and tidy and clean that can be easily segmented. Okay, I'm only going to use when I'm given the certain amount by the government, and that's what I've told, that's what I'm going to use. Maybe some people can do that, and hats off to them. But the majority of those having a substance use disorder, that's not how it works. And so for multiple reasons, this has nothing to do with a quote unquote safe supply, but it is a very good marketing term.
So may I ask a supplemental question?
Yes, sir.
Is the promoting of this concept, safe supply, then in some cases deceiving and even increasing harm?
Yes, it is. Because it's giving the impression that we can safely use drugs. It's giving society the impression that it's okay to safely use. Again, I don't doubt that some people use these drugs and their lives aren't ruined. I mean, again, just like some people go 170, 160 kilometers on the highway once or maybe every day for a month, and they don't get into a car crash. Again, that's not a reason to say those things are safe. They're not safe. They increase your risk. When you go over the speed limit, you increase your risk of death, injury, bodily harm, etc. When you use any of these drugs, you greatly increase your risk of a negative consequence, not just you, but to your family and society, which we don't talk about that enough. We don't talk about the victims enough. And so it is a total misnomer from a scientific point of view to call it safe, because there can't be a supply that's safe. Inherently, these are dangerous substances.
Really appreciate you speaking to that. Thanks.
Thanks.
Thank you. Emily Avery, we have next.
Thank you very much, Chair, and good morning to you, Dr. Sabat. And thank you for your time and your willingness to share your expertise with this community. I can't tell you how much we all, I think, appreciate the common sense approach, the simplified answers that you're providing to us, and straightforward and to the point. And I think that's very important for all those who are watching. I wanted to stray away from some of the political discussions with respect to guests before this committee, but I think inevitably questions of politics, of government policy are intertwined with topics like this. And so I ask this of you because from the onset, and in addition to the incredibly capable resume and the breadth of experience that you've demonstrated before this committee this morning, we know full well that you've worked for various U.S. administrations on both sides of the political spectrum. So I would venture to say that you've got a wide array of exposure to the different political ideologies in both Canada and the U.S. With that said, we've heard a very thorough analysis from you with respect to the role of the medical community in opioid prescribing. And I think you mentioned a little bit when you were talking to my colleague, MLA Rosen, about the role of various actors within this entire topic that we're discussing. We could talk about multiple angles, I think, but I want to know if you can impart any information on this committee with respect to what you believe the role and responsibilities of drug manufacturers are in this particular debate. Have they recognized that they play a key role in how their drugs are used? Are they involved in the debate of safe supply at all? What can you tell us about what approaches governments are taking, both south of the border and here in Canada, with respect to what they are asking of drug manufacturers, especially when you mention things like, and I think maybe not a direct quote, but you said just earlier that BC has one of the worst rates of opioid abuse in the Western Hemisphere. I think I'd like to hear from you if you can comment on what responsibility the drug manufacturers are taking and what governments are doing to hold all actors accountable in this particular debate.
Well, thanks for the question. I mean, I think like so many things, sometimes government can be late to the switch and react when things have happened. We were seeing in the United States, the undue influence of companies like Purdue Pharma, which right now, I mean, Purdue Pharma is a dirty word to everybody in the United States. You can't utter that word and there isn't an ounce of sympathy by anybody. Which is pretty astounding. I mean, the only people to hold that kind of place in drug history would be the tobacco companies. But I would say that Purdue Pharma is even lower on the rung than even today than the tobacco companies, which also, by the way, willfully lied to the American people and to the really global population for over a century about the harmfulness of their product because they needed people to use a lot of their product to make money. So, and that's really the worry here is that we have private companies that have an incentive for people to use heavily. And that was the issue with Purdue Pharma and other companies in the United States. And there were people in government that tried to raise alarm during this crisis in the mid 2000s and the early 2000s at the time when we were reconsidering what pain was, but they weren't really listened to because those lobbying forces were very strong. I do not know, although I'm here right now, I do not know the Canadian landscape with regards to that as well as I do the American landscape. But I will say that I have been astonished in my very light even researched for the work before this committee for today, to see the connection between some people that even publish papers on on how great this idea, for example, of safe supply is, their connection to distributing and manufacturing and being part of the supply chain of what would be a quote unquote safe supply. I was actually astonished at that because I did not expect to find that, and I don't have the exact names or anything in front of me now, but I was astonished to see that there were some of those interests, those research, quote unquote research, and corporate interests, or at least supplying interests. I don't know how they've set up their company. It could be a nonprofit. I don't know. But supplying interests that were intertwined. And that was astounding to me because in the US, we are really paying a dear price for really not looking at manufacturers as being responsible. We just kind of the people didn't want to look at them. And I think we have to. I think we have to understand that they do play a role in this. And I think we have to tread very, very lightly if we are flirting with the idea of increasing the availability and use of pharmaceutical drugs and wanting to encourage that, which is what safe supply by definition does. I think we have to tread very lightly because we are dealing with multinational corporations that have intense lobbying capability. Even if you try and write them out of the law, they find ways into it. And again, that's why I really need to stress to this committee that this has to be a bipartisan issue. There's nothing partisan about. We all want to have an open debate and discuss. I don't think anybody wants a closed debate. We want an open debate and discussion. And it was regrettable to me to see the nature of kind of some of the responses even to this committee's inquiry, because it's important to inquire about something that's happening. I mean, frankly, in a lot of countries, including my own, if you didn't like a topic, you never would bring it to a committee and have a hearing. You didn't even want to discuss it. So I think this committee should be lauded for even wanting to have the discussion. But it's regrettable to me that we're not even. I would love to hear from the advocates, and I think you would too. It's regrettable to me that we don't see that, and I don't know if that's out of line to say that or out of order here, or inappropriate. But it's how I feel, especially as sort of somebody that has a heart in both countries. When I look, to Canada, I think about a country that really should value and does value a civic discourse and debate, frankly, a lot more than my own country often does, especially with today's very intense partisanness. So that's regrettable to me.
About 1 minute, Emily Milliken.
I had another question that would probably take me more than a minute to talk about. So what I'll do is I'll just go to a question that I've asked for a couple other presenters, and that is, do you know of any evidence in your experience on both sides of the aisle, all that kind of stuff, do you know of any evidence that showcases that increasing supply or even safe supply, whether or not it can, any evidence to show that it leads to better outcomes for users? And I think you mentioned family and communities as well.
Yeah, no, I mean, the evidence is the opposite. The evidence is when you increase the availability of harmful substances, you get worse outcomes. You get worse outcomes when it comes to children, child welfare, family unity. You get worse outcomes when it comes to hospitalizations and emergency room rates. And you get worse outcomes when it comes to life expectancy and even short-term things like education, workplace issues, and safety. And so, again, that is why we have to understand that there is a role for these drugs in a very regulated way, but in the way that is often presented as a so-called safe supply, I worry that that will get out of hand very quickly and produce negative consequences overall.
Thank you, Dr. Sabat, for joining us here today and for your presentation. Hope you enjoy your stay in Canada. You're going to have to come to the other side of the Rockies next time you're up here and check out Alberta. You'll love it. If you haven't already, and just appreciate your time and hope you have a great day. We're now going to...
I would love to. Thank you, committee.
Perfect. We're now going to take a break for lunch and reconvene here at 1 p.m. So thank you, committee. members, and hope you enjoyed your lunch hour. We're going to get right back into it because we have lots of good presentations this afternoon. So I wanted to be able to invite Dr. Best to our committee work, and thank you for being here today. We are doing 10-minute presentations followed by 20-minute Q&A with the members of the committee. And without further ado, I'll pass it over to you to be able to dive right into your presentation. So thank you again for being here, and look forward to hearing what you have to say.
Many thanks for inviting me in. I thought I would just start with a little bit of background on who I am and what my background is as a foreigner, and a foreigner with a funny accent. I thought that might be a useful way to start for me. So I am a champion and advocate for addiction recovery, and I have worked in the addictions field since the early 90s. So I've worked in a range of settings. Starting in clinical settings, I worked in a methadone maintenance clinic, a heroin detox ward. I've worked in an alcohol detox ward. And in the last 10 or 15 years, I've primarily researched around recovery. I've worked in clinical research and policy settings. So I'm an experienced academic. And the first thing I wanted to say is that people will have seen my name and potentially said, here is somebody on the recovery side of this debate. And I hope other people will say to you and have said to you that this is an unhelpful false dichotomy between recovery and harm reduction. And that essentially one of the key things, I guess, and not the most sophisticated lesson to learn is you don't recover if you're dead. And we need to have a system which allows people to stay alive long enough to enable and facilitate recovery. I also come at this from a slightly unusual angle, in as much as I am a criminologist. So I want to talk on some of the debate about crime and crime evidence as part of the discussion, but I will come on to this later. So much of my early work, when I worked in South London at the Institute of Psychiatry, was about peer use of naloxone. So I think it's really important that we have a recovery-oriented system that is predicated on a model of hope that ultimately aims to support people's individual journeys to recovery, but that system starts with community-focused harm reduction activities. So I want to make it clear, I reject the false dichotomy of recovery and harm reduction, but nonetheless, I will come at this primarily from a recovery perspective. There are two models that I would like to champion as part of that approach. The first is CHIME, that the fundamental aim we should have for all interventions are connections, hope, identity, meaning, and empowerment. And that the process for right across whatever system of care you use is fundamentally about that process of creating positive social connections that generate hope, that allow the building of positive identity, that give people meaningful activities, and that is something I will come back to, and that in turn allows effective empowerment of individuals. So the two fundamental premises for me are any part of a system, harm reduction, front end, community focus, right through to treatment pathways, are the importance of generating hope and aspirations for meaningful change. In outcome studies, and particularly the drug outcome research study in Scotland, DORIS, led by Neil McKechnie, people were asked, what do you want from interventions? Interventions right across the board. And fundamentally, people will say they want to lead a meaningful life that's free from problem drug use. In their survey, when asked about their aspirations, very, very few people answered that what they wanted was endless maintenance supply of drugs. And we get too bogged down in debates about segmentations of populations and utterly patronizing and unhelpful notions of some people are too complicated and too difficult and complex to hope for lasting change. But in my world of long-term recovery, we know that many of the people who effectively achieve lasting and stable recovery are people who would have been regarded as incredibly complex cases. And the treatment system cannot be paternalizing. It cannot segment off a hopeless group of people for whom the best we can hope is to keep people alive and keep people out of jail. For everybody, the aspiration should be about long-term change and the viability of long-term recovery. So anything that offers indefinite provision of substitution therapies of any kind is, in my view, massively risky, and the evidence in favour of those kind of interventions is fundamentally premised on a public health and a public safety model, not an individual well-being model. And it's crucially important that we have a model in place that inspires and provokes recovery. Now, as you will hear, the debates around safe consumption and the provision of medications of various kinds to people, the key is not the principle but the practice. And the practice of systems, and I want to go right back to the very start of my career when I was doing my PhD in Edinburgh. And at that time, in an attempt to control the spread of HIV in Edinburgh, a major risk to the population, the substance using population at that time, encouraged secondary distribution of methadone. Now, I then started interviewing people whose primary drug use was diverted methadone. And if you start providing a poorly regulated process and a poorly regulated market, you will create a secondary distribution network. It's also important to say, I think, that if we create centres, physical locations and centres, is around the challenge of the location and the management of the location. There has been some debate in the lead up to this select committee about crime and crime nexuses. Well, one of the things that I think is important to say, and then there have been challenges of the viability of your crime evidence around the way data is collected. But the history of criminology is predicated on the assumption that we are very poor at collecting crime data. Whichever measure you use, self-report, well, people will tend to report the crimes they've been caught for and not much else. Arrest data is basically a function of both policing priorities, policing resources, and the competence of the criminal. Conviction data and prison data, even more so. All crime data is flawed when we talk about reporting. So the two measures that you have used, public perceptions and police calls, are no more or less flawed than any other indicator. And what they represent, and from what I totally accept, you can't make causal claims, but you can very rarely make causal claims in social public policy debates in any case. What the data you have suggests is the problem of the social nexus of criminality. So where people congregate and there are identifiable, visible congregation points, you have high risk of normalizing substance use and behavior. And the other problem you have, as in my own previous experiences of being involved in injectable methadone clinics, is people then start to reject earlier options, lower tier options. Why should someone go through the drudgery of daily prescribed oral methadone when there are things potentially much, much appealing? And I guess given the cost typically of running safe consumption rooms and the cost effectiveness debates around safe consumption rooms, there are challenges to the number of places available. And we wouldn't want there to be a high number of places available for people to potentially access what should be a treatment effectively towards the last resort. And for me, the challenge fundamentally is around location. How do you avoid this becoming a location? And to give you an example of this, many years ago, I worked in South London at St Thomas's in a ward called MOPD4. And MOPD4 was a ward specifically for HIV-positive heroin injectors who were typically on very high doses of methadone and other prescribed medications. It became a nexus for bullying, and it became a nexus for diversion. The challenge there was people with HIV were typically given very high doses of methadone and benzos, and other people took them off them, bought them from them, diverted them, and they were used to fund other forms of drug use. The question is not whether it's appropriate to prescribe somebody, but how you can avoid some of those high-risk scenarios. And to link that to the Edinburgh study I mentioned earlier, the big problem is once you have diversion, you have a different set of risk factors of initiation and overdose of naive populations to whom the substances weren't prescribed or made available, Linked to the complexities that drug use is typically not a rational process. It's driven at the high end of problematic use by compulsion, tolerance, withdrawals, and cravings that mean the planning of behaviors to get into specific sites to use in particular ways is challenging and problematic. So for me, the key kind of conclusions about this is you need to focus very much on questions of pathways in, pathways out. How you create recovery-oriented, hope-based models, even for people who engage in safe injecting facilities or safe consumption facilities. You need to create expectations and beliefs throughout the system that this is not simply an alternative to standard treatment processes. And you need to think very, very carefully about how you create meaningful pathways to and through those systems that are associated with logistics that avoid crime nexus, that avoid diversion and leakage of drugs into the community, and that avoid creating normalization and normalized expectations of serious and problematic substance use. And that cannot be on an indefinite or maintenance basis, because effectively what you then create is a public health, public safety crisis at the cost of individual well-being and choice. I think just to conclude, what for me is a challenge here is that you provide a very small level of provision at a very high cost for a small number of individuals that, while it may evaluate positively from a satisfaction and experiential point of view, doesn't provide the level of long-term change and hope to individuals, but not only to individuals, because we learn from recovery models, the goal is a ripple effect from the individual to the family and the community. And any evaluation has to be relative to recovery-oriented models that attempt to provide provision that is effective across all of these three populations. And that the beneficiaries of any intervention within a recovery-oriented model, which you should have, has to take into account all three of those populations moving forward. I see my clock is down to 9 seconds, so I will stop at that point.
Thank you, Dr. Best. We'll now open up for question and answer with the members here, and we'll start with MLA Milliken.
Thank you, Chair, and thank you very much for your passionate presentation. It came across, and I can see, based on the fact that I think through your background, you having experiences not just sort of philosophically about these kind of issues, but also on the ground and actually hands-on. You mentioned at one point that you were in there actually doing the interviews, and that comes across with your level of knowledge. So I do want to thank you for that. I also like the logic of just listening with regards to this hope-based model for meaningful change and a meaningful life being one of the main points of what addicts often are looking for, flushed out from your interviews. So I guess one of the things, though, that I have a question on is you mentioned that diversion is something that you can pretty much expect. I was wondering if you could maybe expand on that, because jurisdictions with safe supply, they experience diversion. I was wondering if you could explain a little bit as to why it happens, and perhaps if there's any kind of mitigating factors to try to stop it as well.
Yeah, sure. So I think let's start with the principles and experience of diversion. People generally don't want to take their drugs in stigmatizing clinics in sterile clinical conditions. So we generally operate on a contingency model where if people are using in a controlled way, they are allowed to take homes. And I'll give you my own experience of methadone maintenance clinic in South London in Camberwell, where I worked for 2 or 3 years. We had our own on-site pharmacy, and people would generally Monday to Friday be dispensed to in the clinic. They would have to be breathalyzed to make sure they weren't alcohol intoxicated to avoid central nervous system depressant overdoses. They would be provided with their medication. They would have to take some orange juice or water afterwards to ensure there would be no spitbacks, and they would leave. But it was open from 9 to 5, Monday to Friday. On Friday nights, people would get takeaways, simply on cost effectiveness and staffing grounds. And for roughly a quarter of our clients, Friday night would be party night. They would take their weekend take-homes and they would go down to Camberwell Green, just a few hundred yards away, and they would swap, they would sell, they would use a combination of things. And by far, this is certainly not everyone, but a significant proportion. We had around 400 clients in that clinic. And the problem we had was that they were not using according to the guidelines and recommendations. So they would sell, and by Monday morning, when I would arrive at work at 8:30 on Monday morning, there'd be a large number of people in severe withdrawals because they either sold their methadone or swapped their methadone, and they were then withdrawing over the weekend. And one of the challenges of prescription-based systems is the problem of non-compliance and the management of non-compliance. So we had problems of combination with alcohol, of benzodiazepine use, prescribed and non-prescribed, and the challenge of systems. And as a criminologist, you have multiple sources of potential leakage. You have staff sources of leakage, and you have client sources of leakage. Unless you're going to operate a system that's 24 hours a day, 7 days a week, 52 weeks a year, you will face significant challenges of diversion of substances. Diversion of substances is problematic in a couple of ways. One, it means non-compliance with whatever regime they were prescribed under, and two, potential leakage to vulnerable non-using groups and populations. And I think one of the big challenges you have, and it's a valuable commodity, and the purer the substances you provide and the further away you move from things like methadone linked to, the higher the risk of both diversion and the creation of an illicit market around those clinics and communities. And this is where the danger of the drug crime nexus potentially grows.
Follow-up, member?
I guess what I do is just switching course a little bit is what are the objective measures to determine whether safe supply is effective?
I mean, I guess that they would be potentially predicated at three levels. So you'll have the individual level where traditionally there would be health measures and the traditional measures of drug treatment outcomes, which would be in 6 different domains. Impact on substance use, so illicit substance use, external illicit substance use, physical health, psychological health, social networks, meaningful activities, families, and criminality. So that would be the individual level. From my point of view, as a recovery advocate, I would also add to that citizenship and global well-being and quality of life. And I think one of the challenges about potentially offering something that may reduce the likelihood of moving towards recovery-oriented or abstinence-oriented models is, are you potentially reducing the likelihood of the person achieving employment, achieving reunification of families? Now, one of the things that I've always thought was a myth and a shibboleth was the idea that there is a substantial proportion of medicated populations who are high functioning and achieve these things regardless. And I think one of the challenges of this question is really around what measures you have. So they would be the individual measures of well-being. You then would add to that potentially family measures and community measures. So you'd have measures of community satisfaction. The notion of outcome is not a simple measure. And one of the things we've learned from a recovery model is we switch from thinking of the individual as the unit of analysis to the individual being part of a broader system of how does it impact on the individual, how does it impact on their family, how does it impact on their neighbourhood, and how does it impact on their community. So public health and public safety are kind of community factors, but there are broader factors we'd want to look at as well. Sorry if that was too messy an academic answer.
Thank you, Doctor. Next up, we have MLA Yao.
Thank you so much, Chair. And Dr. Best, thank you so much for taking the time to speak to us and our committee. It's greatly appreciated. I just want to reflect on some of the comments you made and just clarify the context, if you will. And I'll finalize it with just a final question to you. You talk about trying to keeping people alive until they can be treated. And you talk about recovery systems that respect the individuals and that, the models must promote things like positive social connections, meaningful activities, etc. And then you kind of talk about how, or you mentioned that some people will reject lower tier options like oral methadone for other alternatives. I guess my question to you, based on all these comments, is that in the field of addictions, are there truly substantive options available for those for the addicted individuals, or is providing the actual pharmaceuticals or drugs a very clear and patent reasonable treatment for people? Thank you.
Okay, thank you very much for the question. The first thing I'd want to say is, from the best evidence we have available, of all people who have a lifetime substance use disorder, 58% will eventually achieve stable recovery, meaning 5 years of continuous sobriety at some point in their journey. So we know that for the majority of people, long-time recovery-oriented change is a viable option. So, which also obviously leaves you with the corollary or the flip side, which is 42% of people don't. I think one of the dangers has been that we potentially are too inclined, far too quick in systems terms, to write people off and consign them to that world of saying, well, the best we can hope for you is to keep you alive and keep you out of prison. One of the great successes of recovery models, and one of the things that's astonished me throughout my career in different countries, including Canada, has been the astonishing capacity and resilience, particularly of peer-based models, to support people into recovery. Now, I think for me, this is a question of mechanics, not a question of philosophy or principle. I have no problem with the idea of substitute prescribing. I have no problem with the idea of overdose prevention, naloxone programs, needle exchanges, or indeed safe consumption sites, on the grounds that they are predicated and embedded within a peer-based, recovery-oriented model of care. So the idea would be nobody gets stuck in methadone or any other form of parking lot, that we don't just abandon people. And look, there's a huge danger. And one of the most contentious studies I've ever done, and I apologize for going back to methadone prescribing, but it's relevant to this point, is that the idea of substitute prescriptions is there's three component parts. There's the substitution pharmacotherapy, there's the psychosocial intervention, and there's care and case management. Well, when I did a study in Birmingham, that we looked at every person who was engaged in substitute prescribing in Birmingham, and on average, they were seen once a month for an average of 9 minutes. And the danger is the pharmaceutical intervention, the pharmacotherapy dominates, and nothing else happens. And so the mechanics of treatment has to include this much broader psychosocial path and psychosocial support system. And, for me, it's not about whether you provide any particular interventions. It's how it's part of a broader model of care that offers a genuine chance for family, meaningful activity, employment, decent housing and education. And if you offer something like safe consumption as a standalone intervention for a small group of people, it doesn't help your system and it doesn't do any of those challenge, stigma and reintegration things.
Follow up?
And just a very quickly follow-up, actually a question provided by my good friend from Banff, Kananaskis. You mentioned that 58% of addicts will recover on their own initiative. Does that number decrease where safe supply exists, or does it increase? Is it a factor in areas that do provide safe supply? Thank you.
Yeah, I mean, the evidence simple, and let me be clear, I didn't say people recover on their own. I said 58% of people will eventually achieve stable recovery. We don't have good enough evidence to say what the community factors are that predict that and how much that's related to safe supply. And I don't think safe supply is sufficiently either uniform or evidenced as a mechanism of change to allow us to assess the attribution of that figure. So my apologies, I don't think the science is good enough to tell us that at this stage.
Thank you, member. Next, we have MLA Fry.
Thank you very much. My question is based along your comments about recovery-oriented care. So our government has been very bullish on this. We've said very publicly, our minister has stated it, we've stated it, you know, we are looking at a recovery-oriented continuum of care. So to me, the idea of safe supply kind of flies in the face of that recovery-oriented system of care or continuum of care. But I also see that there are harm reduction techniques that can be used to achieve that end. So I was just wondering if you could expand on your experience and the experience that you've seen. What harm reduction techniques are the most effective at achieving a recovery-oriented system of care, and which are the most detrimental to that?
Yeah. Let me just say that the whole idea of a recovery-oriented approach or a recovery-oriented system is predicated on the notion of continuum of care. So it's entirely consistent with the notion that you will attempt to engage people in recovery interventions from their first contact, whether that's with a needle exchange, whether it's with a prescribing clinic, or indeed with a safe consumption room. The idea would be to say, for people, we meet people where they are and we work with them towards that model. Now, some of the most wonderful and effective recovery-oriented systems pick people up in accident and emergency rooms, pick people up at the gates of prison and take them to mutual aid or 12-step meetings, get them involved in recovery housing, get them involved in peer-based recovery support services. The starting point is not so important. The focus on medication, the focus on providing safe supply, to me is secondary to the how it's done and the why it's done. If you ask me about what a recovery-oriented system in practice means, it's a recalibration of the allocation of resources, much, much more to community-focused, strengths-based reintegration efforts. But it doesn't mean that those things couldn't be done within an entire gamut of harm reduction services. Now, it seems perfectly legitimate to me. You asked me about the most effective. I think something like Take Home Naloxone works beautifully. So potentially somebody coming out of prison who is going to meet somebody to take a peer to take them to a recovery residence, take them to a 12-step meeting, but they have naloxone in their backpack when they come out. That seems to me a beautiful alignment of the two things. There's a safety net, but there's a pathway to long-term change. The challenge once you go down the road of prescribing services is they create networks, they create expectations, beliefs, and identities, frequently stigmatized identities, that are hard to reconcile. So the mechanisms through which they are set up, through which diversion is prevented to prevent significant community harms, and through which hope and aspirations, meaningful aspirations for change is crucial. So I think in some ways I'd want to avoid kind of league tabling or ranking harm reduction interventions, because for me the crucial point is how they can be utilized to initiate the process of what will typically be community-based and peer-delivered approaches to recovery-oriented models, which are increasingly strongly evidenced that what we want to do, even for somebody in a safe consumption room, is to start identifying what recovery capital they have and how we can use peers, social networks, and community resources to build that recovery capital, way beyond the point they'd want to use a safe consumption room or a methadone prescription.
Is there a follow-up, member?
No, and I'm sorry, Mr. Chair, I have to turn off my video from time to time or else I start to lose my internet connection.
MLA Stefan.
Sure. Thank you for that presentation. I just have a question about the argument that you sometimes hear in respect of self-supply, that there are some who are suffering under these addictions that are not interested in recovery, and that the opportunity to keep them alive is an ends that justifies the means of self-supply or safe supply. I'm just wondering if you could speak to that argument, that someone who is alive has a chance in the future of recovery, and that somehow safe supply keeps them alive. Thanks.
I have absolutely no problem with that argument. As you're probably aware, and I'm sure you're aware, the question of motivation is a really complex, fragile and changeable thing. So the notion that somebody is interested or isn't interested in recovery seems to me almost a misleading concept, and it's exposure to successful recovery peers and recovery groups and recovery organizations that inspires and promotes change. I don't see any of these things as kind of blocks of things that happen inside people's heads. And I'm not particularly wedded to or convinced by any of those clinical arguments that would say somebody is too addicted or too complex or too messy to be thinking about recovery models. I think that's paternalizing and dismissive and problematic. The other part of your comment and question of do we need to provide supports and medications to allow individuals to stabilize, to enable them to benefit from recovery models? Absolutely. Now, I think there's a significant challenge around the duration and the intensity of that offer. I think we have to offer recovery-oriented models at every point, in safe consumption rooms, in prescribing clinics, in needle exchanges, because the ultimate point of a recovery model is not to write people off. Everybody should have that hope of change and be exposed to role models and successes that allow them to aspire to and believe in and be part of that change model. And that's a very different kind of social network and social identity, the kind that may well be at risk of happening in maintenance clinics and safe consumption sites, where an entirely different socio-cultural and value set of identities and expectations linked to stigmatization accompanies that approach and that model. So for me, I think, yes, of course, you have to keep people alive, and you have to offer, any recovery-oriented system has to have a full range of options. But the weight and the emphasis and the strength is on creating hope and supporting change.
MLA Amory with about a minute left.
And thank you, Dr. Best, for providing us with your presentation and your perspective as it relates to your observations and findings. I note from your bio that your research interests include things like recovery pathways, recovery capital and its measurement, social identity theory and implications for recovery, addictions treatment effectiveness, and family experiences of addiction and recovery, among other areas, of course, that you have undoubtedly evaluated. Your area of expertise and your focus of study appear to be recovery-based. Yet this committee here is contemplating the viability of quote-unquote safe supply. It's become clear from our work here, even just today from the people that we spoke to, including yourself, that safe supply is not really a uniform theory. That means that the jurisdictions that have embraced this concept have different methodologies and applications, and I think that's fine. I mean, different jurisdictions have different challenges, and therefore I think have to apply models that work for them. Dr. Best, my preamble was long, but my question is going to be quick and simple. I want to know whether there is any evidence that you can describe to this committee or that you are aware of which reconciles the concept of safe supply and addiction recovery. And in simpler terms, just to kind of narrow it down a little bit, for the uninitiated like me, it appears for me that the two cannot be reconciled. I'm not sure that supplying those with the very substances that lead them into addiction recovery is the answer. Am I wrong?
Okay, no, you're not wrong. I mean, I would just want to quickly say that although I'm a recovery advocate, champion, and researcher, my background and my history as an academic is in clinical research and treatment services, including a diverse range of harm reduction experiences. I have no direct experience of safe supply. I would not prioritize safe supply within a recovery-oriented model, but I cannot provide you with evidence that says they are inconsistent or contradictory. Safe supply, if it's going to be embedded, has to be within a recovery-oriented approach and has to fulfill the criteria of moving people forward as much as possible into recovery-oriented models. I'm sorry, that's a far too short answer to what's a very big question.
That's quite okay, because we actually ran out of time there. So I'm sure we could have spent a lot more time asking questions, and we are very much appreciative of the time that you did take with us and your presentation, and feel free to join us for the rest of the afternoon as well if you're interested. So thank you, Dr. Best.
Many thanks.
Sincerely appreciate you. Thank you. Next up, we have Dr. Lynette Reeb, who has actually been with us all day. So thank you, Doctor, for being with us here today. and being a part of our conversation. We look forward to hearing from you. So you have 10 minutes for a presentation, and then we'll open it up for Q&A, and I'll pass it to you.
Great, thanks for having me. I don't see my slides on the screen.
Oh, it's coming. There you go. 10 minutes starting now.
Okay, great. So thank you for asking me to come and share some thoughts on safe supply. Next slide. I have no relationship with the pharmaceutical industry. I am going to be getting a small honorarium from the government of Alberta to sit on one of their committees, and no perceived conflicts of interest. Next slide. For this session, I'd like to be able to place the current crisis in context, to list some pros and cons of safe supply, and to identify other evidence-based options to address the opioid epidemic. Next slide. Substance use represents the top preventable cause of death worldwide, according to the World Health Organization. Next slide. It's not just an opiate crisis. In Canada, alcohol is the #1 cause of hospitalization, with more admissions than opiates, stimulants, and cannabis combined. And even hospital admission rates for cannabis are similar to opiate-related causes, but we're not hearing about any of this in the media compared to the opiate crisis. So really, we have an addiction crisis in Canada. Next slide. Some of the previous speakers that you heard today went into detail around the opiate crisis, so I won't go in great detail on this slide, but just to understand there is a significant role of big pharma that created this, including lobbying, paying for textbooks, promoting pain as the 5th vital sign, and incentivizing physicians to prescribe opioids. They also recruited patient advocates to be the face of pain, and did not bring forward the people who are becoming addicted or having trouble with their medication. Palliative care docs and anesthesiologists opened chronic pain management centers using medications typically confined for hospital use, and other doctors followed suit. So doctors played a role in one of the waves of the crisis, and with no upper limits to prescribing, guided by the patient's pain experience and sympathy of the doctor for the patient. And we now know that 75 to 80% of injection heroin users started with a prescription opioids to which they got tolerant. Opioids not only relieve pain, but cause pain, which I do research in that area. And opiate withdrawal pain particularly is a driver of reinitiation. And again, we can talk more about that in the question period if you like. Then the tainted blood supply with contamination of all sorts of things you can see listed on the slide. Next slide. Just to understand that all of the things you see listed on the screen can affect someone's addiction liability or that risk to a population, but the key thing that cannot be done without is exposure. So if you don't have exposure, you don't have a substance use disorder. And by reduction of exposure or elimination of exposure is one way to intervene. So we have not talked at all about primary and secondary prevention, which is part of what's important. Next slide. When the COVID-19 pandemic hit, there was a need to self-isolate and quarantine, and an increase in contamination of the drug supply as just supply chains got cut off and rising deaths. The BC CDC and the BC CSU created new guidance on prescribing pharmaceuticals, opioids, stimulants, and benzodiazepines that were outside of evidence-based treatment. So these were not medications that had been studied or that usually were provided for opiate agonist therapy, OAT. This was to take home unsupervised that people could use orally, but many people were snorting and injecting. The term pandemic prescribing, also known as risk mitigation, also known as pharmaceutical alternatives, also known as safe supply. These are all euphemistic names, but I will use the term safe supply in this talk because that is what the committee is choosing. This is a form of medicalization versus decriminalization and legalization, which again, we can talk about in the question period. Next slide. So the hope for outcomes, again, there's no published data, but the hope for outcomes when this was rolled out in British Columbia is that it may be desired by a certain segment of the drug using population. It may reduce stigma to those. It may be more convenient than if they had to go in and get something supervised. It may help if someone had to quarantine. The hope is that it would mitigate overdose and that it might be less expensive than having someone have to witness in a supervised setting, an injectable medication, which is inexpensive to have all the setup and the nursing staff, and that it may link users with care providers and encourage treatment. That is the hope. Next slide. There's a presentation last week by a colleague I respect, Dr. Paxton Bach from the BCCSU. It is not my data. I'm not going to present it in detail. This is my understanding of what they said from that hour-and-a-half presentation. Just some of the key features, that there's been 6,500 people who have received these medications. There's no intervention on this scale that would be rolled out without prior evidence that could be peer-reviewed. So it's quite marked. And certainly no evidence was presented that it decreased overdose risks. It was anecdotal information around acknowledgement of diversion and around some patients wanting to unlink from physicians and nurses and healthcare providers altogether to get this information. There was some anecdotal evidence that people could self-isolate a bit better. And that some people did report some increased use, but many reported that they continued to use illicit substances. Next slide. The concerns I have over this is that on a population level, this is an experiment with no published data, the consequences of which may take years to see. Just like with prescribing opioids for pain, it took years to see all the impact. The potential benefits may be confounded. For example, in the data, they showed that about 83% of people of the 6,500 were either on an opiate agonist treatment, methadone, Suboxone, injectable, hydromorphone, or slow release oral morphine. They were already on that when they went and accessed the safe supply, or within a week of accessing safe supply, they got this. So it was mainly being given out by addiction doctors when people were already in, or as a way to help hook them into care. So when you look at potential benefits that may be rolled out by this research, it may be confounded because the benefit that they're seeing may actually be from the opiate agonist therapy itself and not as much from the safe supply. So this needs to be teased out. Some harms may not be captured right away, like infections from injecting, tablet formations that are meant to be taken orally, youth who may uptake and diverted supply, diversion, which includes increased availability, decreased cost of pharmaceuticals on a street level, which can drive up use and addiction in the long run. If we think of China and the opium that was pushed into the country, and Ohio and the OxyContin, as well as spread across Canada and the US. So these are the effect on society. Increased wealth and power of drug dealers purchasing low-cost diverted medications and selling them elsewhere. So one of my colleagues at Vancouver General Hospital told me a number of months ago that there was one of the well-known drug dealers from the downtown east side was in for a medical condition, and she sat down on the edge of his bed and asked him how he was doing financially, and he said it was the best thing that had ever happened to him. He made $1 million this year from buying up safe supply off the street from people who had it dispensed to them, and he sold it across Canada and to the United States for making a huge profit, because the street price of these drugs, as Dr. Matthews had mentioned, has tumbled down to just 3 or 4 pills for $1 instead of $8 to $10 a tablet. And so you can sell it elsewhere for an enormous profit. The other issue of coercion of vulnerable individuals being asked to sell their supply in order to have dealers make supply. Next slide, please. So some of my other concerns is that even the term safe supply can give this false impression that they're safe to use and inject, which may encourage needle use and youth to increase use. And people can still overdose on medical grade opioids. We have years of experience with pharmaceuticals. If diverted, an opiate naive person, someone who had not been using, can still overdose, but they thought it was safe because it was a medicine. Also, some sell their safe supply to buy fentanyl. There are people seeking fentanyl, as we know, and they can still overdose because of the fentanyl. And all stimulant trials have failed. So giving safe supply in the terms of fentanyl does not seem wise. You could give an opiate blocker instead to prevent contamination of overdose due to opioids if someone took a stimulant, but no one's talking in such terms. Next slide. Other concerns, it may pull people from stable treatment. We'll need to see. We need studies that look at this. It may delay treatment readiness if it's done outside of a treatment context, just handed out in a public health forum instead of by addiction doctors who are using it just as an engagement tool. It may palliate a treatable disorder, and this is one of my big worries, that just like with cancer treatment, if we did not offer all the evidence-based treatments and pull people into care and instead just gave them opioids and palliated their disease, there would be an uproar. So we have to make sure we don't do that with this particular condition. There will be people who decline treatment, just like with cancer. There are people who want homeopathic remedies instead of taking surgery, radiation, and chemotherapy, and that is their right, but that is not where we put public healthcare dollar. Special groups, youth, older adults, pregnant women, we're not sure how it affects them, and there has been no exit strategy articulated. Once you're on, what's the indication to get off? They were presenting the other day that even people who have negative urine drug screens for the medicine that they're prescribed are still given more of it. So what's the exit strategy? Next slide. There are evidence-based options, and I'm sure your committee will go through these: primary and secondary prevention, medication-assisted therapies like buprenorphine, methadone, slow-release oral morphine, and something we don't have in Canada but is available in the US and Europe is extended-release injectable naltrexone. It's like naloxone, only it lasts a month. You can inject it, and it's on board for a month. You can ask me in the question period about that substance if you like, but we don't even have it available in Canada, though I worked with some people to bring it in on special authority, but no one paid for it. Any government paid for it. And it now, the latest study out on this shows that it's even better than buprenorphine in terms of sobriety rate, 70% at 1 year and craving rate 1 out of 10. So behavioral treatments abound, and I've listed them there. Next slide. So to save lives, we need to fund primary and secondary prevention, offer treatment to all those who are wanting it, make treatment accessible and affordable, bring extended release injectable naltrexone to Canada, which is good, especially for people who have safety sensitive work because it's an opiate blocker, so people are sober when they go back to work. Cover new formulations of buprenorphine, supervised consumption sites and injection sites need to be embedded in care if they are used, expanding naltrexone, prioritizing pregnant women, youth, and helping employers get workers back into treatment and back to work. And if you are going to decriminalize, do it in the Portuguese model: house, treat, medical care, etc.
Excellent, thank you, Doctor. I'm pretty sure the first question from the member was to ask you to just work through the last couple slides that you have there. I heard that question, so feel free to take a couple more minutes to finish your presentation.
Great, thank you. So what I tried to do here is to put in a small decision balance. Now, obviously, people on all sides of this, and I do respect people who are coming at this question from all different angles, and I don't envy your position to having to make decisions here, but we're all trying to get the same thing, which is a reduction in death and increased quality of life. But what I tried to do is look at a decision balance of providing safe supply, the pros and cons, or no safe supply, pros and cons. So with safe supply, the pros, there's many, but just in a nutshell, you may save some lives, particularly if it's used to engage patients onto proven treatment, especially in a contained environment like a supervised injection site where they can't take that medication home and divert it. The con is that it may cost lives in future. Diversion can increase street availability, the way it's rolled out right now, creating the next wave of opiate crisis, palliating a treatable disorder, and the legal risk of supplying unproven treatment. We all know the class action suits that are coming against organizations that promoted high-dose opioids for the pain crisis. So some of the pros of not having safe supply is resources can go to proven treatments and save lives, and do not add to the next wave of the opiate crisis. And there's many other things that I've already articulated in the talk. The cons are that some people who use drugs may decline or fail treatment, and they may die. Just like with cancer treatment, there's some people who can't access or who decline treatment. The legal risk of not providing safe supply when the federal government and BC is rolling out safe supply, you'll have to think of that on your decision tree. Next slide. So in summary, safe supply is an intervention that may reduce risk to some individuals, particularly when combined with opiate agonist therapies, but to others it may bring harm. Other evidence-based interventions exist, some of which I've talked about and some of the other speakers have talked about. Prevention, treatment, healthcare, housing, and jobs all reduce harm. Next slide. Here is the next two slides are some of my opiate-related research, including on pain. I did some of the first research with my residents around the link between seized drugs and the contaminated drug supply when comparing coroner data. Next slide. It's also part of the research. And next slide, I've listed some key naltrexone studies for you just because it's not a very well-known intervention. There's tons of evidence on buprenorphine and methadone, but I thought I would provide the naltrexone information because it's not well-known here. Next slide. And I'm just recommending a book called Empire of Pain if you want to understand the origins of the opiate crisis and the role of the pharmaceutical industry. Thank you very much for your attention, and I'll take questions.
Thank you, Doctor. That was a lot of information. We're very appreciative for you taking the time to prepare that. So we're going to open up for Q&A, and we're going to start with MLA Milliken.
Perfect. Thank you, Chair. And I really do actually appreciate the fact that we offered the opportunity to go over those last few slides, because you actually answered one of my questions with this decision balance. One of the things, though, at the outset of your presentation, you had mentioned that you'd be listing potential. Oh, we're getting some feedback now. Listing potential pros and cons. And until that decision matrix that you put together, I was actually having trouble finding pros that you were listing. So with your comment then in summary where you say safe supply is an intervention that may reduce risk to some individuals, particularly when combined with OAT, but to others it may bring harm. That of course is opioid agonist therapy. Agonist therapy. My apologies on that one. Do you know of any studies or data-based backing to show that that is or is not the case?
What I presented was what is the hoped for outcomes. That's why some of the public health interventions have promoted trying safe supply, but there is no data, there is no published data that would support this intervention thus far. There's research being done now, but there's no supported data thus far. There's an anecdotal report that some individuals are saying they benefit.
And something else, follow up?
Yes, sir.
Something else that you had mentioned early on in your presentation, you had stated opioid-induced pain sensitivity. And then also pain in withdrawal. I was looking at, I could see a possibility where safe supply may be effective with regards to dealing with potential pain from withdrawal. However, I just wanted to see if you could expand on that, especially on the opioid-induced pain sensitivity.
Yeah, so ironically, first I'm getting some feedback. Someone has their mic on, but ironically, opiates are very good to relieve pain in the acute setting, but very soon there are many changes within the nervous system that will make the person more pain sensitive. And then also once they're tolerant, when they have withdrawal, they can have generalized aches and pains, as well as pain return to old injury sites, even healed injury sites that were pain-free prior. So this tremendous pain that you can have can drive use. So it's one of the key risk factors with opiate use that's different than all other substance use is the tremendous pain people can have. Safe supply is certainly anything that can relieve withdrawal may have some benefit, but it's not a safe way to deliver that. Truly, to use evidence-based medicines, methadone, Suboxone has been shown to decrease pain by about 50% when people are converted over to it. And if you can detoxify someone and they can go on a non-opioid, this can also be an effective intervention if they don't have an underlying chronic pain disorder that needs an opiate for treatment.
Do you have a follow-up?
Thank you. And I will take the opportunity actually to shift us in a bit of a different direction. Just when the beeper went off, you had started what I thought was a potential part of a discussion with regards to, you'd mentioned Portugal. And Portugal has some notoriety with regards to decriminalization of drugs. It's also, it's my understanding that there may have been some successes with regards to bringing down overdose rates in that country.
Yes, very much so.
And if you could then potentially, because it's my understanding that they may have been able to and I'm not trying to answer the question for you or anything like that, but they may have been able to do it without using safe supply or supervised injection sites, is my understanding. But again, yeah.
Your understanding is correct. They took a treatment-focused lens, and how they decriminalized is not the way it's being proposed in Canada and elsewhere. How they actually decriminalized is if you were found with a substance, a small possession of small amounts, and they had it, they had documentation and agreed upon what level that would be, you would be brought in and interviewed by a social worker and sometimes others to determine if you have a substance use disorder. If so, you would be offered treatment paid for by the government up to a year, including residential treatment if needed, access to medical care, psychiatric care, all medications paid for that would treat your substance use disorder, and then vocational rehabilitation. Then they pay for the first 6 months to a year, they pay 50% of your salary to your employer wherever you can get integrated into the job force. So you go from being the least likely to be employed to the most likely to be employed. They offered housing, they offered all of this integrated care within the community, and it had extremely high quality of life improvement ratings from the people who participated. They dropped their overdose rates, their incarceration rates, their HIV rates, and they diverted some of that money to healthcare that had been to the criminal justice system. And then they used some of the money from the criminal justice system at a low level to help secure their borders from importation from that tainted supply. So they were able to, in this way, really help their society.
MLA Milliken?
Yeah, I would actually, you've essentially, it sounds like you've told us that it's actually quite a complicated, any potential solution is complicated and has many different factors. What
it is.
Yeah, and so taking from you on that, then what evidence-based medications and social interventions are we then lacking in our sort of armament to fight the opioid crisis?
Right. So some of the good things you guys have been doing in Alberta is you created a 24-hour, 7-day-a-week access so someone could get on to buprenorphine. So that's excellent. You're increasing both residential treatment and also second stage recovery, as well as sober living communities, because some people need years to fully stabilize given the years of use and damage to their brain and to their bodies and their emotions, etc. The other things we need are the evidence-based, both social interventions as well as evidence-based medications. And I had listed those during the talk. One medication that we don't have at all, like I mentioned, is naltrexone. I helped to spearhead a letter of 34 addiction doctors in 2018, and we helped Jane Philpott, then the Minister of Health, understand that naltrexone was an important thing in the armamentarium. And she got Health Canada to allow this medication to come in, but no health authority or province paid for it. And so on their formularies, and so people could not access this. So injectable forms of that and injectable forms of buprenorphine as well as all the other medications that I listed in my talk.
Did you have a follow-up to that, member?
I would have a question that would be unrelated, so if somebody else. And
Emily Yao, and then we'll come back to you.
Thank you very much, Chair. And Dr. Reeb, thank you so much for taking the time to speak with us. You have a very lengthy resume here. I'm just going to clue in on just one or 2 points of your resume, which is that you're a member of the Canadian Society of Addiction Medicine's Education Committee, as well as a key committee member with the College of Family Physicians of Canada's Competency Creation Working Group for the Certificate of Added Competence in Addiction Medicine. In your presentation, you mentioned that 75 to 80% of heroin users started out as prescription users, or they were given prescription opioids for their pain relief and whatnot. I think that's reflective of certainly our physicians contributing to this crisis. In your position, do you see more education, more competency being targeted at physicians to try to alleviate this issue, or? Yes.
Thank you very much for that question. Yes, so I've done addiction medicine for close to 30 years now and been working in pain medicine or pain rehabilitation as a family physician for about 18 years. And I have taught through the College of Physicians and Surgeons in British Columbia, through the College of Family Physicians. Also, I'm part of the Pain and Addiction Common Threads Committee in the United States for the American Society of Addiction Medicine. So I've taught nationally, internationally, and locally, and to med students and fellows, all trying to help with understanding rational prescribing. And I teach physicians on how to help bring down some of the outrageous opiate doses that we were doing. People are doing a much better job in the medical profession now with this. There are guidelines now. There used to be no guidelines on upper limits that you could go to. So I used to see patients come in very frequently on hundreds or thousands of milligram equivalent of morphine. And now that's very rare in the pain setting. In the addiction setting, it's still quite high. But we have done all this work to help mitigate over 2 decades. I've taught doctors on how to help mitigate and have more rational prescribing, and then to have it unleashed on the other end by saying you can just provide, safe supply. It's very confusing to doctors because all someone has to do is say that they have an addiction or take fentanyl once so it's in their urine drug screen, and then they have access to this very high potency opioids, whereas they've been curtailed on the chronic non-cancer pain side. So it's creating quite a bizarre environment right now.
Thank you. No follow-up.
Follow-up? Okay. Any further questions? I think, MLA Milliken.
The question that I was going to ask was actually well done just previously. However, I do have another one that I could just, if you would allow, yeah. Okay. In your presentation, you mentioned that overdoses still occur with safe supply, and that most were due to the individual being alone. Given your experience, would a more effective prevention of overdoses be focusing on reducing the use of opioids by yourself versus toxicity of the drug being used?
Sorry, I don't think I mentioned anything about being alone, although that is a risk factor, using alone. And also, just to clarify,
presenter.
Yeah, just to clarify, I don't think I said the first part of your question exactly either. But I'll address the issue of being alone. I didn't say that people overdose more with safe supply. We don't know the answer yet. That's being researched. The issue of using alone, obviously, that's one of the public health interventions, is trying to use with a buddy and trying not to use at the same time your buddy is using, to have naloxone present, to go to, if available, a supervised injection site, that kind of thing. That's kind of a base level of harm reduction.
Thank you. No, thank you.
Perfect. MLA Rosen.
Thank you. I just have one follow-up, actually, to my colleague MLA Yao's question. You raised an interesting point, I think, that the medical community and doctors undergo years of training and schooling to learn how to properly prescribe and diagnose medications. But in a safe supply model, individuals could just walk out and essentially get the drugs almost without a proper prescription or allowance. So would it be fair to say that the concept of safe supply almost undermines the medical community and undermines the work and the teachings that doctors do and go through?
On the one hand, I can say very much so. And at a bare minimum, it certainly confuses people a lot. There are certainly advocates in the medical community. There are a lot of public health doctors who think that this would be the way to go. But again, I liken it to when the palliative care doctors and the became involved in the treatment of chronic non-cancer pain, and anesthesiologists who'd only worked in the hospital, and they'd end up prescribing these high doses. They didn't see the impact. As an addiction medicine doc, I got the fallout from their prescribing practices. And so these public health interventions, though they look good on the surface that, oh, this is compassionate and may help, in the broad societal view, it may actually cause harm and also be very difficult for doctors to gauge how much to give. I may be proven wrong in the long run. That's the thing about evidence in medicine. So to keep an open mind and try not to demonize people who have alternate views. But I think trying to make the best evidence approach, there are other ways to tackle this problem.
Follow up? No?
Thank you. My question was a follow-up to somebody else's.
There we go. MLA Milliken.
Yeah.
Just a general question that I've put in some way, shape, and form to several of the presenters. This committee is tasked with examining several aspects of safe supply, including whether there is evidence that a proposed safe supply would have an impact on fatal or non-fatal overdose, drug diversion, or associated health and community impacts. With that in mind, is there any evidence that you know of that that access to a safe supply of opioids or other substances for people who are addicted to or dependent on these substances reduces their likelihood of suffering a fatal or non-fatal overdose?
We don't have any data on this yet. And in terms of, there's lots of anecdotal reports of drug diversion, however, right now.
Excellent.
But with any intervention, there will be individuals who benefit, just like when we prescribed very high doses of opiates for pain, there are some people who came forward who said, I can get back to work, I'm doing better. But there were other people who got addicted and harmed and their families were destroyed. So you have to look at the overall picture. And this is an intervention that has been rolled out in a population before we have the data for it, and also before we can look at all of the different harms that may be associated. Some of the data is kind of being targeted toward potential benefit, I feel.
MLA Milliken.
Thank you. And somewhat aside, on one of your slides, you had mentioned that palliating a treatable disorder is not good medicine. It's been discussed with a couple of the other presenters, but who would you say are the advocates then for safe supply?
I think it's a combination of a certain section of user groups that have been given voice and have their voice being heard now that may not have been heard. People who may not want treatment, but see it as it's more of a civil libertarian argument that they have the right to do anything, and they want to be able to use this like any other person uses any other substance. Personally, I don't even think the public can handle open access to antibiotics. I don't think open access to highly addictive substances is the way to go. The second are public health doctors who see the harm of people dying and wanting to make an intervention and seeing that this may be it. Also, the healthcare systems and all those social supports needed are not built in yet. They've been not funded by governments in the way that they needed to in order to avoid this crisis. So what do you do in the meantime? It's also, I think, there are advocates, parents and others who have lost people who have died to this, who have gotten on board to think this may be the solution. I personally don't think it is the solution, but because that's become, even government is funding some of those groups to be able to say, just like, pharma did fund advocacy groups to say that they needed the opiates as well. So I think this is a bit of a tough topic and very emotional, but certainly I think people are going to die on either side of this issue. So it's difficult, but what you want to do is try to mitigate harm in the best way you can and bring forward the most evidence-based treatments possible and bring people into care as well as possible.
Thank you, Dr. Reed. I believe that is it for questions on our side of things. So I just want to thank you very much for joining us, for your presentation, for your passion and the work that you do. I also wanted to thank you for sharing your art with us today. I particularly enjoyed the piece. The joys of living in a Zoom world is we get to enjoy so much of everybody's art. So thank you for that.
Yeah, my husband did that.
Oh, really? Oh, it's a beautiful piece. Pass that on to him for me. So thank you for being here with us today.
Thanks for asking me.
All right, now we have Sharon Koivu here with us today, Dr. Sharon Koivu, sorry. Thank you so much for being here with us today to be able to present. So first, we're going to open it up for you to be able to present to us for 10 minutes, and then we'll go from there into a Q&A with the members. So without further ado, I will pass it over to you. Thank you.
Okay. Great, thank you. Members of the Select Special Committee to Examine Safe Supply, good afternoon. I know you've had a long afternoon, so thank you very much for the opportunity to speak with you today and share my experience. I have been a physician in Ontario for over 35 years. I have worked in primary care and as an acting medical officer of health. I have a certificate of added competency and focused practice in addiction medicine and palliative care. My role in addiction medicine has principally been to offer an inpatient consultation service in an urban hospital. Most of my addiction work involves seeing patients who are admitted with infectious complications of injection drug use. From 2012 until 2021, I was the only physician in my city working in this capacity. I provide a non-judgmental, client-focused approach using harm reduction strategies, meeting people where they are. I initiate or continue opioid agonist therapy as patients are ready and connect them with appropriate community resources. We now have what is referred to as a safe supply program in my area. It is delivered at the Intercommunity Health Center. Because it is run through a community health center, it is associated with wraparound services such as primary care and housing first initiatives. These additional services have been shown to improve health outcomes. The initial inclusion group for Safe Supply was women who were street-level workers at risk and who were experiencing homelessness or were vulnerably housed. This program has since expanded. In my experience, this Safe Supply program involves prescribing opioids, often in large amounts. While the program promotes daily dispensing, many patients that I saw receive scripts for several days, even 1 to 2 weeks at a time. The most commonly prescribed drug is immediate release hydromorphone tablets, also called Dilaudid or D8s on the street, as they usually are 8 milligram tablets. Cadian, a long-acting morphine capsule, is occasionally prescribed. Also, I am aware that some clients have received injectable hydromorphone. Now, it is important to recognize that clients receive a prescription that they fill at a pharmacy. Taking the pills or medication is neither verified nor witnessed. This should not be confused with a witnessed injectable opioid agonist therapy program. This Safe Supply program is not part of and does not provide a supervised injection site. Initially, I was supportive of Safe Supply. Locally, we had had a huge problem with heart valve infections called tricuspid valve endocarditis, as well as an increase in HIV in people injecting drugs. In listening to their stories, I discovered that patients with these infections were injecting hydromorphcontin, long-acting hydromorphone. Working with infectious disease and research experts, we were able to prove and publish this causality. After the Safe Supply program started, I noticed an increase in horrendous infections. These included spinal osteomyelitis, an infection of the bones of the spine, epidural or spinal abscesses, at times causing paraplegia, and brain abscesses. Previously, I had rarely seen these infections, and I wanted to understand why they were increasing. In speaking with these patients, I discovered that approximately 90% were injecting Dilaudid. While some of the patients I saw were in the Safe Supply program, over 80% were not. They were buying drugs diverted from the Safe Supply program. Their experience, suffering, and deaths are not captured by data provided by the program. The number of people suffering and dying from infectious complications of injection drug use in our region is high. We found that at least as many people die from infections from injection drug use as from overdose. Since Safe Supply began, I had a significant decrease in patients who would consider initiating or continuing evidence-based opioid agonist therapies, such as methadone or Suboxone. Increasingly, patients requested safe supply, even those who have been stable on an opioid agonist therapy. Many acknowledged that they were motivated by the income associated with diversion. When I first began my addiction work in 2012, most of the patients that I saw had developed an opioid addiction after being prescribed opioids for chronic pain. This has changed since Safe Supply. I am seeing much younger patients who have started by taking diverted opioids. The flood of diverted opioids on the streets has led them to be relatively inexpensive. It can be cheaper to buy a D8 than a beer. This has led to an increase in the number of people using opioids. People can afford to use higher doses. This in turn has resulted in an increased demand for more potent opioids, ultimately increasing the demand for fentanyl. I have also had patients who are in the Safe Supply program that divert their Dilaudid to buy fentanyl. This does not exclude them from the program, even if they are not using any of their prescribed Dilaudid, as the program generally does not perform urine drug tests. In our community, there is more fentanyl now than before the Safe Supply started. We have had an increase in deaths from overdose. I personally have witnessed much suffering and death as a consequence of infections caused by injecting Dilaudid, which patients informed me that they got from the Safe Supply program. I have also had patients that died of overdose who were in the program. For me, these are not statistics. They are people that I knew, valued, and cared for. I'm here today to honor them. My commitment has been very personal. From 2015 until 2021, I lived within 1 kilometer of the Intercommunity Health Center. I chose to live in this amazing, diverse neighborhood to actively promote harm reduction and be part of a community in which a supervised injection site was being considered. Going for a walk often meant chatting with people who had been my patients and truly meeting people where they are. This was my home. I moved into the neighborhood before the Safe Supply program was a concept. I watched the community change firsthand. These changes included public health outcomes and concerns. A large amount of diversion has been from one specific pharmacy located near the Intercommunity Health Center. This has led to an increase in people staying in tents in surrounding parking lots and in neighboring storefronts in order to get quick access to diverted drugs. I knew many of the people staying in these tents, some who were experiencing homelessness, and others who were actually housed. These conditions are very unsanitary and may explain some of the increase in infections. Local businesses are also affected, as accessing them can entail stepping over drug paraphernalia as well as human feces. Storefront windows have often been broken or vandalized, resulting in some businesses closing altogether. In my personal experience, crime in the residential neighborhood has also increased. This includes things such as bicycle theft, car break-ins, and stealing copper pipes and wiring from homes. I understand that this is generally not from people in the Safe Supply program, but largely from those requiring money to buy diverted drugs. I have family in other parts of the city that are socio-economically similar who have not experienced this increase in crime. Finally, sadly, because the program is not witnessed, vulnerable clients at times must surrender their prescribed drugs to other more dominant members of the society or community, or are at risk of physical violence. These victims can be the same people that the Safe Supply program was initially intended to help. Members of this committee, we are in a crisis. We need to be open-minded and innovative in our approach to solving this crisis. We need to reduce harm, not just pass suffering from one person to another. Unfortunately, a program that involves prescribing large amounts of unwitnessed opioids has unintended side effects. Diversion causes great harm. In my experience, it has led to an increase in the number of people using opioids and the use of higher doses. As people seek a greater high that cannot be met by prescription opioids, they may turn to toxic fentanyl. Community safety may be compromised as people seek ways to pay for diverted drugs. And as I can attest to, injection of pills designed to be swallowed can cause tragic suffering and death. The flooding of prescription opioids onto the streets started this crisis. We need to be more creative and passionate to end it. Thank you.
Thank you. Thank you, Doctor, for the presentation. We're now going to open up for members to be able to ask questions, and we're going to start with MLA Milliken.
Thank you very much, Chair. Thank you, Dr. Koivu. I want to express my thanks. Obviously, you're on the front lines with regards to healthcare, and so I'm sure not even just with regards to the issue that we're talking about today, but obviously with the experiences that we've all had for the last couple of years here. So again, I do want to thank you for all that you've done. And given that you have what seems to be a pretty solid wealth of experience with regards to on the ground of Safe Supply, I just want to take, I can't help myself, I have to take the opportunity to say, okay, if I was to champion Safe Supply, and if I was to get it to a point where we were potentially doing Safe Supply in Alberta, what would you do if given the opportunity to kind of help out with creating it, given your experience, to make it as safe as possible if it was instituted? And what I mean by that is you mentioned a few things like historically it sounds like urine tests aren't often used to ensure that individuals are taking what they're supposed to be taking. Perhaps ways to decrease some of the different infections that you had mentioned. Perhaps another one just off the top would be witnessing, things like that.
Okay. I guess I'd start by saying, getting feedback, sorry. I think it's hard to make Safe Supply safe. And there are safer medications such as Suboxone and Methadone that we need to have a lot better access to and wraparound services attached to those. And we can talk about that more. But there are things that can make Safe Supply, even the concept of it, less destructive than it is now. And I understand the moral injury of watching people suffering and dying and wanting to do something to help that. But the problem with Safe Supply as it is now is for every person you are helping that you can see that's in front of you, you could be harming one or two other people that you don't see. So you can feel good about what you've done because the harm you're doing might not be visible to you. And one of the most important things if people decided to have a model of prescribing opioids would be witnessed. Any of the things that even the people who promote Safe Supply say are helpful would still be there in witnessed drugs. And witnessing means you know what they're taking, you know how much they're taking, and you know that you're not adding to someone else who might develop an addiction from the pills that you're prescribing. And I think witnessing to me is the most important. And even things, when people come into the hospital and they haven't had witnessed doses, it becomes very confusing to know what a safe dose is for them because we have no idea how much they're diverting. So normally you can look at what people are prescribed and know what they need. It's completely different and very challenging in hospital to work with people who are in a Safe Supply program. because we don't know what they're taking. And I've had patients who had severe problems such as COPD that were diverting most of their drugs, but if they happen to take them or witnessed, are at risk of dying. So I'd say witnessing is the most important. And the next one would be tying it to a supervised injection site. So if we are, giving pills is not a good thing. If people are injecting, it would be better to be a type of medication that was supposed to be injectable, but also having the injections in front of you in a supervised injection site would be paramount.
Just as a very brief follow-up, you had mentioned perhaps alternatively, or you had mentioned some wraparound services. What would you have been indicating with that?
Well, if you look at a community health center, they have primary care. So whether it's through nurse practitioners or family physicians providing primary care, they often have social work, counseling, housing first models to help people get housing. So the other social determinants of health that we know help people who are experiencing homelessness, vulnerability housed, or at-risk populations, those services are at a community health center. And in where I live, for example, if you go to a methadone clinic or a clinic like a rapid access addiction medicine clinic to get Suboxone, buprenorphine, they're not available as part of the service, I think, and which makes it very, very unfortunate, because those are things that are needed to help with anyone's health outcomes. So I think ideally wraparound services, so primary care, helping to treat people and get people back, helping with vocational training, getting them back into the workforce. All of those things that can be available through a community health center need to be available for people who are using methadone and Suboxone. They shouldn't be essentially discriminated against for choosing an opioid agonist therapy that is evidence-based.
Emily Amory.
Thank you very much, Chair, and thank you, Dr. Koivu, for your obvious passion for this area. It's incredibly important to hear from what you had to say. I'm going to start off by reading a little bit of history about what I have in front of me, and then I'm going to ask you a couple of questions about that, if that's okay. In March of 2020, you published a study titled New Hepatitis C Diagnosis in Ontario, Canada, are associated with the local prescription patterns of a controlled release opioid in the Journal of Viral Hepatitis. The prescribed opioid is safe supply hydromorphone. The study concluded in part that their findings add support to evidence that hydromorphone controlled release use is contributing to hepatitis C virus spread in Ontario. You have provided us in your presentation today with a lot of extra details in relation to some of the impacts that you have observed over the years. Notably, you've said that you've noticed an increase in health-related issue, transmissible diseases, and other related concerns, which you've articulated in your initial part of your presentation. You also talked about the impact on younger patients and the exposure that you are finding with respect to opioids because of their abundance in the market. These are, in my view, some of the foreseeable consequences of increasing the opioid supply in any community. But I was also a little bit surprised to hear when you mentioned that opioid-related overdoses also increased in your observations as well. Now, that was my preamble. My question is relatively straightforward. You had mentioned in your presentation earlier that you had approached the concept of quote-unquote safe supply with an open mind, maybe even a favorable position at the very onset. I like what you said earlier to my colleague, Emily Milliken, when you said that we all have an inherent desire to do something to help those in need when we think that we can contribute. I think you're absolutely correct about that. But I'm also wondering if you can comment for our committee's benefit what information or beliefs or positions you had at the very beginning when you were contemplating a favorable approach to safe supply, how that evolved, how long it took to shift towards this current position, which I believe has changed significantly since that time. And what sort of impacts you've observed in your community with respect to the damage that it's caused in that period of time? I don't think we can afford to have a trial period given that you've already experienced some of these things. And I'd like to hear from you about what has transpired since then. I think it's preferable to hear it from somebody who's gone through it than to try and have it exposed to this province here and find out firsthand. Thank you.
Thank you. I hope I can explain this in a way that I will kind of explain my experience. So in London, actually, I'll just sort of step back. I was a palliative care physician, and I started seeing a lot of patients who were dying of infectious complications of injection drug use. That is what brought me into working in addiction. And particularly the problem we had in London was a heart valve infection, the first heart valve that enters your heart from the bloodstream, called the tricuspid valve. We also were having an increase in our HIV and Hep C, but it's rare to see an increase in HIV and injection drug users. And we found that it was the long-acting, so it's a type of hydromorphone that has beads that were creating this problem. So when Safe Supply came out and they were going to be using a different formula of hydromorphone, the long-acting, or sorry, they were using long-acting before. They were going to be using short-acting, which looks like it dissolves better. I actually thought that might be an answer, that we would have a safer type of drug that you could be giving to patients and decrease the amount of infections. But what I saw, and in a way doesn't surprise me retrospectively, was I saw that we were getting different infections. And in some ways, they were more horrific, because I started seeing people, particularly with spine infections, that were making them potentially paraplegic, so they couldn't walk. So the suffering, there might be less death, but the suffering that I was seeing from these infections was absolutely horrific. And even the suffering I see in palliative care couldn't prepare me for this suffering. And I didn't, as I said, I didn't know what drug people were taking. I had really good relationships with my patients and have for a long time. Being the only one who sees these patients, I had the ability to talk to essentially everybody admitted to hospital about what they took. And the thing that was most striking was that the vast majority of people were taking Dilaudid. So the immediate release Dilaudid that now was flooding our community because it was coming from Safe Supply. And I realized that we had traded one bad thing, tricuspid valve infections, for another bad thing, spinal infections and other infections. And we've actually shown that even though we had a campaign to educate about the tricuspid valve infections, overall infections in our community has increased since Safe Supply. And these are overall horrific injection drug use infections. So I actually thought naively that if I just tell people what I'm seeing, it would have an effect. And I was kind of surprised that when I was saying I'm seeing some really bad things, it didn't seem to have the impact on the people prescribing Safe Supply that I was hoping that it would. It's been really hard to watch that suffering. I can't describe how hard it has been. And people that I have known for years who had developed much more severe infections. And I have patients in the program who have died of overdose that I'd known for years. So I've been touched watching how what I get to see are the ones that are suffering and not doing well. And as I pointed out, I lived in that community. I moved into that community knowing it was kind of an edgy, urban, diverse community wanting to promote harm reduction. I'm normally the radical in a room. where I'm the one really trying to support kind of meeting patients where they're at, I wasn't prepared for how the community was going to change. As I said, people were now living in tents in parking lots behind the pharmacy so they could get the diverted drugs quickly. They're cheaper in the morning than they are in the afternoon. And the impact that all of that has had on our community is really hard to explain to someone not living there. There's a hypervigilance that you have to have that you don't experience when you live, in a rural community or even outside of this community, to know what it's like to really live where this is all happening.
Emily, do you have a straightforward supplemental?
Straightforward, direct. Dr. Koivu, thank you for your impactful response. Increased drug overdoses, deaths, increased social impacts, increased drug use, increased diseases, increased infections, increased exposure to younger communities. Can you describe whether you've observed any perceived benefits touted by safe supply advocates in your community?
I will say I have not seen the benefits, but I will also say that the people that might benefit are then not necessarily going to be in hospital. So I can't say that there can't be benefits to individuals and anecdotally, but I can honestly say that I have seen no benefits, and I have seen horrible experiences both for the patients, the increase in drug use, as I say, the increase in deaths overall, and then the changes in the community. So I have not seen the positives.
Emily Yao.
Thank you so much, Chair, and thank you, Dr. Koivu, for taking the time to speak with us. I'd like to just expand on Mr. Amory's last question to you. Early in your presentation, you mentioned first-stage housing, and that aspects like that have demonstrated to provide effectiveness for people that are trying to rehabilitate. That segues into a conversation we had with the previous presenter on Maslow's hierarchy, and that if we can address their certain needs like their physiological needs like food and clothing, their safety needs like their housing, and their social needs like having peer and family support, that those are proven supports to helping people kick the habits, if you will. What is that a fair estimation on your part that those are proven supports that we can try to address with people over these issues of safe supply?
Absolutely. I mean, if we look at addiction, we used to talk about pillars, which would be prevention, treatment, harm reduction, and enforcement. And we sort of now put all of our weight into harm reduction. But part of treatment isn't just the treatment with the medications like methadone and Suboxone, which are proven evidence-based treatments, but they also include looking at social determinants of health. And we know that they have an impact on outcomes. Unfortunately, they're attached to the community health center. And instead of that being a place where people go to get their evidence-based medicine, they've been connected to the Safe Supply program. So yes, absolutely, connecting those same wraparound services to evidence-based opioid agonist therapy that already exists, such as methadone and Suboxone, would absolutely likely improve outcomes.
I'll follow up.
Excellent. Any other questions from members? All right, seeing none, I want to thank you, Dr. Koivu, for joining us here today and for your presentation and your obvious passion and heart for the work that you do. So thank you, and we really appreciate your time.
Thank you very much for having me.
All right, that concludes our presentations for the day and brings us on to item number 6, other business. Is there any other business that the committee members wish to bring forward at this time? All right, hearing and seeing none, we will move on to item number 7, the date of the next meeting. The next meeting begins at 9 a.m. Wednesday, February 16th, 2022. And with that, we head to adjournment. If there's nothing else for the committee's consideration, I'll call for a motion to adjourn. Member Yao moves that February 15, 2022 meeting of the Select Special Committee to examine safe supply be adjourned. All in favor, say aye. Any opposed? That is carried.